next item on the calendar for the day is House File 4699. The clerk will report the bill.
Senate File number 4699, number 1 on the calendar for the day, an act relating to state government modifying provisions governing health care, the unofficial engrossment.
I recognize the author of the bill, the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker and members. I bring to you today Senate File 4699, which is our supplemental budget bill for health, finance, and policy. So compared to some of the bills we bring forth in this area, this is actually kind of a little bill. It's only 349 pages. Usually, as you know, or often I should say, we have bills that are in the range of 1,000 pages. So this is actually a very small bill. And we had a very small target this year, only $9.5 million over the 4-year budget horizon. But this bill, in spite of being small in its size and small in its budget target, has a big impact. It is a really important bill. So one of the things that it does, and I'm just going to go through this kind of briefly, because it is a sort of a small bill. One of the big issues in this bill is improving insurance coverage. So we know that we have a healthcare system that depends for its financing on insurance models. And insurance, as you all know, that this is already, it's well known that I have this opinion, and I think many in this chamber share it, that the insurance model is actually a really poor way to finance healthcare. But that's the way we do it, and this bill starts to address some of that by improving insurance coverage in a number of areas, and also in dealing with, doing more to deal with the issue of prior authorization, which is that terrible process by which your doctor has to go and beg the insurance company to cover something that you need for your health care. And that system has just seemed to get worse and worse, and is now at a point where it's creating not only problems for patients who can't get care that they need and that is actually covered by their insurance, but also creating a lot of burnout for our healthcare providers at a time when we need more of them. When their time is very limited, a lot of their time is wasted in this process. In terms of improving insurance coverage, there are a number of items that we are proudly carrying in this bill. One of them is, and I would say one that I'm extremely proud of here, is the provision brought to us by Representative Cagle on orthotic and prosthetic devices, improved coverage for that. We're also covering gender-affirming care, although that I believe is passing another bill as well. We're improving abortion coverage. We're covering amino acid-based elemental formula. Thank you, Representative Hicks, for that. And we are covering whole genome sequencing. Thank you, Representative Hemmingson-Yager, for that. And also, importantly, scalp hair prosthetics for cancer patients. Who would think we would have to pass a law to make sure that a person who loses hair because of cancer treatment would have to would not get covered for the hair prosthetic that they need? That is just incredible. But we are putting that into this bill because we have to. So that is some in that. This bill also does a lot to help pharmacists. It increases some of the funding to reimburse pharmacists when they dispense a medication under our fee-for-service Medicaid, medical assistance, as it's called in Minnesota, and does some other provisions too, which we could talk about later. But some of the money in this bill is dedicated toward that. The bill does a lot to address medical debt, which is a provision worked on very hard by Representative Ryer. It tackles the very vexing problem of hospital closures, thanks to Representative Smith. And it explores and begins to do more to deprivatize our public health care programs. So yeah, maybe I'll just pause on that one. But everyone on this floor, I'm sure, knows how I feel about that. I probably don't need to go into it. But there are some real advances here, both in looking at the issue and in starting to kind of pilot a program to do better with our county-based purchasing and basically with our publicly owned health programs. And this is called CAMA. It's an acronym in the bill. And county-administered medical assistance. We also raise rates and do some things in mental health. We know that mental health we have critical problems in mental health in the state. This is a nationwide problem. It's probably a worldwide problem. But we know that we need to do better for paying for mental health care under our public programs. We are trying to do that here. We're raising outpatient mental health rates under medical assistance. We are putting money into respite care for families that desperately need that. And we have a provision here to start to work on a children's residential crisis stabilization rate to help us with those services that's so critical. And thank you again to Representative Hicks for that. So I mentioned that we had a $9.5 million target. We were able to capture some other money in the bill, so there were some money that we were able to spend that we were able to capture from various sources of other unspent monies. And so we were able to spend of this, in this bill, we're spending around $28 million on mental health, which is pretty good from a $9.5 million target. We are spending about $9 million on improving insurance coverage, and the vast majority of that goes to the prosthetics and orthotics, which is so, as I mentioned, is so important. And then about $3.2 million on improving the things for pharmacies and care that is given by pharmacists. And so some of that was carried by Representative Bonner, some by Representative Curran, and we can talk about that a little bit later if folks wish. So that is my introduction. Thank you, members, for your attention, and we have some amendments to get through.
There's an amendment at the desk. The clerk will report the amendment.
He's not here.
Kevin.
Bierman moves to amend Senate File Number 4699, the unofficial engrossment. The amendment is coded A3.
I recognize the author of the amendment, the member from Dakota, Representative Bierman.
Thank you, Madam Speaker. Thank you, members. The A3, members, is an amendment reflecting an update to the governance structure of Hennepin Healthcare System. HCMC is a critical safety net hospital in the healthcare infrastructure of our state. There was an informational hearing last Tuesday for members on the Health, Finance, and Policy Committee, and this measure will provide a more balanced and transparent process for the continued oversight and control of HCMC by Hennepin County. Thank you, Madam Speaker.
There's an amendment to the amendment. The clerk will report the amendment to the amendment.
New Brindley moves to amend the Bierman amendment to Senate File Number 4699, the unofficial engrossment. The amendment to the amendment is coded A27.
I recognize the author of the amendment to the amendment, the member from Chisago, Representative New Brindley.
Thank you, Madam Speaker and members. This amendment, all it does is it will add to the underlying amendment that there will be notice given to the Commissioner of Health when there's an investigation. Just, you know, it's a safety net hospital. There is a public health interest for the state, and so the Commissioner of Health should be aware of what is happening with the hospital. And I would request a yes vote. Thank you, Madam Speaker.
I recognize Representative Bierman.
Madam Speaker, members, this is a great amendment, and I would ask for a yes vote on the A27.
Further discussion? There being no further discussion, all those in favor of the amendment to the amendment say aye. Any opposed say nay. The motion prevails, and the amendment to the amendment is adopted. To the underlying amendment,
Madam Speaker,
Representative Bierman.
I would ask members to support the A3 and appreciate that. Thanks.
Further discussion? There being no further discussion, all those in favor say aye. Any opposed say nay. The motion prevails, and the amendment as amended is adopted. There's an amendment at the desk. The clerk will report the amendment.
Liebling moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A11.
To the author of the amendment, Representative Liebling.
Thank you, Madam Speaker. This is as close as we're getting here to an author's amendment. It just lines up the language in today's bill with language that we passed off the House floor earlier this week. So this is just, as is commonly done, provision is traveling in two places just to make sure it gets through.
Discussion to the A11 amendment. There being no discussion, all those in favor of the amendment say aye. Any opposed say nay. The motion prevails, and the amendment is adopted. There's an amendment at the desk. The clerk will report the amendment.
Zalesnikar moves to amend Senate File Number 4699, the unofficial engrossment as amended, and the amendment is coded A5.
To the author of the amendment, the member from St. Louis, Representative Zalesnikar.
Thank you, Madam Speaker and members. Today I rise to offer the A5 amendment. And this amendment is going to expand some good work that was done last session. And this allows any patient, including a patient that's pregnant, to have a designated support person with them while receiving care. I believe, and I think everyone in this chamber believes, that every patient should be able to have a loved one by their side to navigate healthcare decisions. In joyful moments like pregnancy, in trauma moments like a car accident, in tragedy like cancer, in unfortunate situations of heart attacks, and the list can go on. I've taken a lot of steps to meet with the Minnesota Department of Health, the Ombudsman, to listen on what would be a possible pathway to assure that all patients in the state of Minnesota have access to their loved ones as pregnant, as we would in a moment of pregnancy. Pregnancy, as we know, is an event that happens at certain moments of our life, but we don't know when tragedy happens, and we don't know when change of our health conditions occurs that requires us to have the people that we call family and friends nearest to us in these moments of trauma and tragedy. And I think we can all agree with a 40% increase in mental health that we all need those that we care about by our sides in the most difficult moments. And this bill just lines up the language to mirror the language that was passed last year to support people during pregnancy. And I hope that the members will support this initiative so that when you find yourself in moments of tragedy and crisis and trauma, that you can be with the people that you love and they can be with you too. I think it's really important as we move forward as a state that we mirror the language that we offered for pregnant situations. And I urge you to vote yes. Thank you, and I ask for a roll call.
A roll call has been requested. Are there 15 hands? Seeing 15 hands, there will be a roll call. I recognize the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker, and thank you, Representative Zalesnikar. We've had conversations about this. I think we all agree that when someone is in the hospital, it's a great thing to have a support person with them, and that is the way it should happen. There may be ins and outs to this from hospitals that I don't know about, but at this time I would recommend a green vote by members. Let's accept this and let's go forward and try to figure out a way to make it work. Thank you.
Further discussion. I recognize the member from Polk, Representative Keel.
Thank you, Madam Speaker. Representative Liebling and Chair Liebling and Representative Zaleznkar. Anyway, this I find to be a super important thing because we decided during COVID that maybe families should be away because of contagious issues. But what I have learned through my experience of caretaking is, and you don't want everybody in the room, nor does the hospital want everybody in the room. It's very distracting, but it is really important for some loved one to have that family knowledge about who they are and what they need. And so I'm really thankful that this is being accepted into the bill. I really think that we've kind of missed the boat with making sure that family does join, someone does join, and I appreciate that it's not designated as a person, but as a designated person rather than just family or just that prescriptive, because sometimes I've done things for people that are not close to me, and you really need to know detail at that point when you're doing those things. So I thank you. I just wanted to reaffirm that this is really important.
I recognize the member from Crow Wing, Representative Davis.
Thank you, Madam Speaker. Chair Liebling, thank you so much. I know I can get a little harsh on this House floor at times, but I'm also going to give honor where honor is due. Thank you so much. Chair Liebling, you brought a tear to my eye just now. I honor you. Thank you. Thank you, Madam Speaker.
Further discussion to the A5 amendment. I recognize the author of the amendment, Representative Zaleznkar.
Thank you, Madam Speaker. And members, I too want to express my gratitude to Chair Liebling. This has been an emotional topic for me, and I think many. And when I was reading in the schools this session, it struck me like a dagger when a student said to me that they were dealing with mental health issues because they didn't get to say goodbye to their mom. And she died of breast cancer, and I was lucky I didn't, but it really hit me hard. It was a scenario I really didn't think about was the kids. And I just want to say thank you from the bottom of my heart. Vote yes.
Representative Zaleznkar, would you still like the roll call vote? Okay. A roll call vote has been withdrawn. So all those in favor of the amendment say aye. Any opposed say nay. The motion prevails and the amendment is adopted. There's an amendment at the desk. The clerk will report the amendment.
Nadeau moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A9-1.
I recognize the author of the amendment, the member from Hennepin, Representative Nadeau.
Thank you, Madam Speaker. Members, the A9 amendment is a pretty simple amendment. It makes one little change on page 66, line 4, if you're following along. It puts the payers for our health services on a level playing field. But I think I need to give people some background information. And in general, this deals with prior authorizations. We're going to talk more about this as the day goes on. You know, back in 2020, Minnesota, the legislature passed a law adding new requirements to prior authorizations. They included mandated timelines, a requirement for prior authorization requests. We literally reduced the standard review from 10 days to 5 days, expedited reviews to 48 hours, appeals to 15 days. There was a lot of really good work done in 2020. However, back then, the Department of Human Services was exempted from this law. The language on line 66 of the page 66, line 4 of the bill, it seeks to close that loophole and require the department to follow the same rules that we expect and require from the private sector. My amendment literally just closes one more loophole. The 62M.18 requires health plans doing business in Minnesota to post their data surrounding prior authorization encounters on their website and update them annually. We can go to these websites and we can actually see which prior authorizations have been declined, if they've been further approved. And so what my amendment does is just literally make DHS follow those same guidelines. Without adopting this amendment, we're going to continue to exempt one of our biggest payers in the system from prior authorization data reporting. One of the reasons that I want to bring this amendment forward is because we in the Health Committee have been hearing and talking a lot about prior authorizations this year. It's kind of weedy, but it's really important. And the data that we kind of were hearing didn't seem to support, what we were seeing didn't seem to support what we were hearing until we received a fiscal note just recently. And it's on page 13 of the fiscal note that managed care operations that report, they deny about 3% of prior authorizations. 3%. That's a 97% approval rate. And we know that because they have to report it. And so in the same document, and by comparison, the Department of Human Services denies prior authorization requests 40% of the time when it comes to fee-for-service members. So, and I know that they probably they might respond and say, you know what, well, they ultimately go under appeal and they get approved, and I hope that's the case. And there's a lot of denials in the private sector that also get denied and then ultimately approved. And I also want to point out that in the case of our integrated health partnerships, the same report shows that DHS denies 30% of prior authorization requests. So these are just two statistics that I found in early May. It's only the 9th today. So, and they were buried in a fiscal note, and it's on page 13 of 25, and it's section 12, paragraph 3, it starts in this. And I suspect that if private plans were denying 40% of prior authorizations members, we'd want to know. And the good thing is we do know because they actually report it. So what I'm doing here is my amendment simply requires the Department of Human Services to follow the same rules that we require and expect from our private providers. I hope that the chair will find this as a helpful amendment. I'm not sure, and we can have different opinions. I think, members, on where we fall on prior authorizations, but I don't think anyone is served when we don't have all of the information in order to make those decisions. So, members, with that, I would request a green vote on this amendment. I would request a roll call, Madam Speaker.
A roll call has been requested. Are there 15 hands? Seeing 15 hands, there will be a roll call. I recognize the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker. Thank you, Representative Nadeau. If this had been discussed earlier, I so agree with you. I really do. And I think there is a real problem with lack of transparency throughout the whole prior authorization issue. And so I just want to make a couple of comments about the data that you talked about that was in that fiscal note. That was quite shocking to me as well, that the assumptions in that fiscal note where they said that 40% of the fee-for-service requests for prior authorization for outpatient mental health were denied. That's shocking if that would be true. And in fact, it's not accurate. And this is not to counter what you're trying to do. I am agreeing with you on the underlying issue, but we dug into some of those assumptions, like where did that number come from? And we found that, in fact, that reflects every time a paper is sent back for a new signature or something wasn't quite right. So it's not sort of the net denials. And so you are absolutely right that we don't have a good handle on how we're not comparing apples to apples. And so I support your amendment. I do want to say that there are some costs to it that would not be tracked in our spreadsheet, but we've been told the costs are fairly small. And so I think that we can work that out somehow in conference, because we'll either, they'll either absorb it or we'll find some money in the bill, because it is small. And I do agree with you that it's important that we have transparency around this. And in our public programs, it's not, just the annoyance factor either. It's that we think we're providing care for people in this state. And for us to find out that, in fact, they're being denied something that we think they should be getting, we need to know that, if that is the case. So thank you for your amendment. So I would ask members to vote green.
Further discussion of the Nadeau amendment. To the author of the amendment, Representative Nadeau.
Thank you, Madam Speaker, and thank you, Chair Liebling, and I withdraw my roll call request.
Representative Nadeau withdraws his roll call request. No further discussion. All those in favor of the amendment say aye. Any opposed say nay. The motion prevails and the amendment is adopted. There's an amendment at the desk. The clerk will report the amendment.
Baker moves to amend Senate File Number 4699, the unofficial engrossment as amended, and the amendment is coded A21.
I recognize the author of the amendment, the member from Candy, Ojai, Representative Baker.
Thank you, Madam Speaker and members. I have a simple amendment as well here, too. I think most of you know that we do a lot of good work here on SUD work. The substance use disorder area of workforce is something I'm very concerned about. What this amendment will do is allow us to kind of continue our area in the telehealth world, but when we have a person helping folks in group support, whether it's an outpatient, whether it's inpatient residential, they can get sick. They might have a sick child at home, but they can still really do their job from telehealth. Current law says we can't do that because the staff has to be present in that place. But if the leader of that organization or the leader of that group can't be there because of something that, again, they can still do their job but do it remotely, let's support them doing that. The A21 members allows a short-term allowance of that, maybe 1 to 3 days. It's recorded so that people aren't going to be taking advantage of something like this. But it's important that we keep their support moving along with the people that they trust. And when somebody can be still doing this in a very robust manner remotely, I think this is a good way to do this. It is wholeheartedly supported by our providers out there. They're asking for this kind of an amendment and help. And so, members, I hope that you allow this to be put on today's bill, and I appreciate a green vote on this. Thank you.
I recognize the member from Ramsey, Representative Fisher.
Thank you, Madam Speaker. Thank you, Representative Baker, for bringing this amendment forward. I will also encourage a green vote on this. I will also note that the Department of Human Services has been doing a lot of work in this area with the providers and have made some very large moves in this area already, and looking forward to have that discussion continue in the conference committee.
Further discussion to the amendment. To the author of the amendment, Representative Baker.
Thank you, members. Please vote green.
All those in favor of the amendment say aye. Any opposed say nay. The motion prevails and the amendment is adopted. There's an amendment at the desk. The clerk will report the amendment.
Ryer moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A22.
I recognize the author of the amendment, the member from Dakota, Representative Ryer.
Thank you, Madam Speaker and members. I'm really pleased that the provision to rescind the ability for for-profit HMOs in Minnesota was included in the omnibus bill. To me, it's an important piece of legislation in the interest of the people of Minnesota, patients, providers alike. However, in this iteration of the bill, there have been certain barriers that have been determined, and so with that, I am recommending that we adopt this amendment, providing a one-time exemption for for-profit HMOs that have licenses in this state as of June 1st, 2024, permitting them to continue to operate within the state, and I ask for a green vote.
Discussion to the Ryer amendment. I recognize the member from Rock, Representative Shoemaker.
Thank you, Madam Speaker and members. This amendment makes the bill better. I would encourage a green vote.
Further discussion. Representative Nadeau.
Thank you, Madam Speaker, and thank you, Representative Ryer. I also am in favor of this, but I am curious. We're providing our nonprofits, allowing for-profit to come into the state. I think is good for it's good for people, it's good for patients, it's good for competition. And the one thing that I would like to talk to you, ask you about is there anything in your amendment that ensures that we are creating more of an even playing field between for-profit and nonprofit? We, as you know, 317A is very specific, and it really regulates our nonprofit providers. And I'm just wondering if you could speak a little bit to your thoughts moving forward on how we can make sure that that playing field is as level as possible.
Representative Nadeau, are you asking Representative Ryer to yield? Representative Nadeau, are you asking Representative Ryer to yield?
I'm sorry, Madam Speaker. Will Representative Ryer yield?
She will yield. Representative Ryer.
Thank you, Madam Speaker. Representative Nadeau. Yeah, there are differences in the level playing field between for-profit and nonprofit HMOs in Minnesota. And in fact, back in the late teens, 2017, 2018, one of the assurances was that there would be a level playing field for all players in the HMO business. And at this point, there is work to be done. For example, the state has more oversight into regulation of financials for-profit versus nonprofit. There are limits that on asset transfers for the nonprofits that the for-profits do not face, and I believe that that is some of the work that Representative Bierman will be working on and that I'm committed to working on going forward, because I believe in the principle of a level playing field for all of the players in the state.
Representative Nadeau.
And thank you, Representative Ryer, and thank you, Madam Speaker. And I also recommend a green vote on this amendment.
Further discussion. There being no further discussion, all those in favor of the amendment say aye. Any opposed say nay. The motion prevails and the amendment is adopted. There's an amendment at the desk. The clerk will report the amendment.
New Brindley moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A12.
To the author of the amendment, the member from Chisago, Representative New Brindley.
Thank you, Madam Speaker and members. To set the table on this with prior authorization, this has been, it's been difficult to get fiscal data throughout the session on the prior authorization changes. And this amendment is dealing with just one portion of that, and it's specifically dealing with chronic conditions. And I just want to talk for a moment about what this can look like and why this matters. You know, things like, I know that 90% of the chamber is going to gloss over at this point because this is not interesting to most people. However, things like drug formularies change from year to year. Things like new medications, new generics, things like that come into play year after year. And so by removing the prior authorizations, specifically when it comes to chronic conditions, things like that are missed. When there is no prior auth, then drugs will need to be paid for that are not necessarily on the formula or that formulary or that have changed. And it is tricky, which is why in the fiscal note on this bill, MMB assumes that many conditions and treatments will be affected, but that the costs are not possible to estimate at this time. So the fiscal note very specifically says that this will affect a lot of different conditions and treatments. However, they don't estimate the costs. So the problem we run into there is that because the costs are not delineated in the fiscal note, they're also not accounted for in an appropriation. That doesn't mean that there won't be a cost. There indeed will be a cost. It's just not accounted for. Further in the fiscal note, it talks about CGIP specifically, and it says the fiscal note it says, our fiscal note assumes that 86.6% of added costs will be paid by state agencies in the form of employer premium contributions. So we do know that there will be additional costs. We just don't know what they are. And therefore, we don't have an appropriation in the bill to go with them, which really throws this out of balance. It means that the bill overall is not in balance because of these additional costs. Now, Madam Speaker, Chair Liebling, Representative Bonner, I would say this is actually, I'm not offering this as a political amendment. I'm not offering this as a gotcha amendment. I believe it's something that really does have to be addressed, and it really does have to be dealt with. Because there are costs that we are not accounting for in this bill, as laid out very clearly by MMB in the fiscal note. So at this time, Madam Speaker, my intention is to withdraw the amendment, but I wanted to make it very clear that we need to be aware of this issue with the appropriations not matching the potential costs of this moving forward. So I hope that we will take this into conference and make sure that we deal with this issue so that when the bill comes back, we have a bill that's going to be in balance and we have a bill that we are going to be able to pay for. So at this time, Madam Speaker, I would withdraw the A12 amendment.
Representative New Brindley withdraws the A12 amendment. There's an amendment at the desk. The clerk will report the amendment.
Schumacher moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A13.
I recognize the author of the amendment, the member from Rock, Representative Schumacher. Schumacher. Thank you.
I don't know how I can't answer that, Madam Speaker. That's sad for me. Thank you, members. The A13 amendment today requires that providers use the automated systems that are already in the underlying bill to file their prior authorization requests. This helps with the way that prior authorization is supposed to work. Against what we've heard somewhat today is that prior authorization, when working as intended, actually works. We hear complaints from providers about what they experience in the process, and a lot of the times we find out later that the problems that they have with the process is because they're using antiquated types of systems to do it, when you're supposed to be looking at the new and most modern ways to provide health care to people, but you're still using a fax machine to submit your prior authorization request. You start running into trouble, and when that's the trouble you're getting, that's an easy fix, but it's not going to be fixed easily through a policy change or just removing prior authorization uses in the system as a whole. And so we want to make sure that prior authorization, the way it's intended, is provided here and can be used in the most effective way. Prior authorization works too as a second check on the physicians and the healthcare providers to ensure that we have more eyes on these. Just as we had earlier, a little confusion here, that's just how human nature is. And so a second set of eyes is helpful with that. But we don't hear that kind of testimony in committee or on the floor or from constituents when prior authorization gets it right and actually helps protect consumers from and patients from a bad treatment course. But of course, those are anecdotal, and we don't hear those pieces throughout that. And so what this amendment is doing is just helping the providers modernize their systems so that they can do things the right way. I do think that from a federal level that this will be coming forth as a requirement too in the coming years. And so I'm happy to see that as we're able to utilize prior authorization more in the future. But unfortunately, as I looked at the amendment as it came forward today, it is a new mandate on providers, and I'll be speaking against mandates later. And so to stay consistent, I'm going to withdraw this amendment today. But just wanted to make the point here that the challenges that we have with prior authorization, it can go both ways in this. And so I thank you and the chamber for your time.
Representative Schumacher withdraws the 813th amendment. There's an amendment at the desk. The clerk will report the amendment.
Schumacher moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A23.
To the author of the amendment, the member from Brock, Representative Schumacher.
Thank you, Madam Speaker. The A23 amendment is a way for us to address some of the deep concerns that those of us who have been looking at the finances of the prior authorization pieces in this bill, what that's really going to cost the state overall. In the Health Committee, Representative Nadeau talked about and posed the questions about what the cost is going to be on this. We didn't have a fiscal note at that time, but Representative Nadeau took the time to look at previous fiscal notes from previous years on similar proposals and tried to extrapolate what he could from that, and he estimated at that time that it would be $100 or $200 million. I think it was closer to $200 million, and if he was half wrong, the cost was still about $100 million, if I remember that piece right. And of course, that was just extrapolation from previous pieces, and it's not apples to apples in every way. But when the fiscal note came back here, many members who read the fiscal note and analyzed it were surprised with the numbers that actually did show up in that note. And some of the assumptions that were there left us a little confused. And so in Ways and Means, I asked about this, and really the response was that, well, the numbers that are there, if they don't meet what the fiscal note had there and what the budget had, that will be dealt with in the forecast, and it'll just be picked up there. And so this amendment really just says that instead of just being picked up by the forecast, these overruns would be taken from DHS and the MMB budgets, as they're the ones who put the fiscal note together, and they could have done a little less on the assumptions and a little more of looking at previous fiscal notes like Representative Nadeau did to come up with their numbers. I would ask for a roll call.
A roll call has been requested. Seeing 15 hands, there will be a roll call.
And would ask you to vote yes. Thank you.
I recognize the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker. Well, I'm going to ask members to vote no on this amendment. You know, this just isn't the way the budget works, and it just isn't at all workable. For one thing, it's fine. Anything we do around here, especially with forecast programs, it's always an estimate. You never hit the number right, and it goes into the forecast. What we decide to spend goes into the forecast, and it gets adjusted there, and that's just the way this works. It's an imperfect process for budgeting. But, in this particular one, this just is completely non-workable. I'm sorry, Representative Schumacher. I understand your concern, but we wouldn't even know. How are they even going to know if there's increased utilization from this bill? It's not even accounted for in that way. And more importantly, what if restricting prior authorization results in better health care for people, which reduces costs? That's the goal, and I think that could very well happen here. We could be reducing costs. So if we reduce costs in medical assistance, then of course the forecast numbers for medical assistance go down. So I don't know, maybe you want to have something here that says if the forecast numbers go down, the agencies get the extra. It would make as much sense. So this just doesn't make sense the way the budget works. I don't want to get too awfully wonky about it here on the House floor, but it is a complicated business, and while it's a kind of a clever way to think about it, I guess, it's just not workable. So please vote no.
I recognize the member from Olmsted, Representative Quam.
Thank you, Madam Speaker. And frankly, it's probably confusing to the people watching. The amendment is saying that if we're doing something that's going to cause spending beyond what was in the budget, they don't spend it. I'll have a hard time explaining that to my constituents that, oh, we have a budget, we pass stuff, but we're not going to restrict agencies from spending more than what's in the budget. This is a little bit more of a complex statement than that, but if we're going to be debating this, we should really get into those details Frankly, I think the intent of this is commendable. Stick within the costs that we projected, and then maybe we phase in other things once we see there's going to be more cost. So I hope we can vote green.
I recognize the member from Chisago, Representative New Brindley.
Thank you, Madam Speaker. This amendment really addresses some of the things that I was just getting at, because it's true, to Chair Liebling's point, everything we do is an estimate, and which is why we have these forecast adjustments, and we realign and make sure that things are being done properly. The problem with the underlying bill and the problem with what we're doing with these changes to prior auth is that we're not getting estimates. And in fact, I mean, like I said, MMB assumes that these things are going to be affected, but it also says those specific costs are not possible to estimate. It doesn't say there will be no costs. It says they're not going to estimate them. And so, unfortunately, what's happening in the underlying bill is that because they have not quantified, they have not given us an estimate on those additional costs, we have chosen to ignore that there will be additional costs. But there will. And so I appreciate the Schumacher amendment saying, listen, Minnesotans should not be on the hook for that. We should find that in existing budgets. If we are going to pass legislation out of this body that is going to have costs that we are unwilling to account for, then the departments should find that in their own budgets. This is a great amendment. This is a great amendment. I would also say that, you know, as a legislative body, we could choose to appropriate money. We could choose to appropriate money knowing that there will be costs. Even though MMB is not giving an estimate, we could do that. And we could give an appropriation to ensure that we are covering those costs. But we've chosen not to do that. So this is a great amendment from Representative Schumacher. I would encourage everyone to vote yes.
Further discussion to the Schumacher amendment. The member from Hennepin, Representative Nadeau.
Thank you, Madam Speaker. And thank you, Representative Schumacher. This is probably the biggest struggle, I think, with the bill. And I agree with Representative Liebling that, you know, we've struggled with identifying the cost. And as Representative Schumacher mentioned early, when I looked at this, there was a Senate file, and it was Senate File 3204. And there was a specific fiscal note that was put forward for CGIP. And at that point, it projected those expenditures from 2020, fiscal year 20, all the way to fiscal year 23. And just the CGIP increase due to the prior auth removal increased the cost to CGIP by $20 million. And so that's a small percentage of the population of our public programs. So if we get this one wrong, members, we're going to break the bank. This is a significant change. And we can argue, we can debate, we can discuss, we can talk, you know, shoulder to shoulder about those things that we want to make sure that are not limiting access to care for people. But make no mistake, prior auth is not about service. Prior authorizations are about paying. That's what this is about. So we had a lot of discussion in committee about this, and we struggled coming up with the cost. And I think adopting Representative Schumacher's amendment today, I think would allow us to kind of work with this a little bit more. If it needs to be kicked out in conference, it can be kicked out in conference if we can't get there. But this has a significant and lasting cost to our programs, both public and private in Minnesota, and it deserves some real significant attention. So today I would vote yes on the Schumacher amendment, Madam Speaker. Thank you.
Any further discussion? To the author of the amendment, Representative Schumacher.
Thank you, Madam Speaker and members, and thank you for the discussion on this. I would say one way or another, we're going to be paying for this, and so if members want a little more transparency in where that money's going and where that's coming from, they should vote green. Thank you.
There being no further discussion, the clerk will take the roll. Members, please vote. The chief clerk will call the names of the members voting remotely.
Carroll. Hewitt.
Hewitt, no.
Hewitt, no. Cagle.
Cagle, no.
Cagle, no.
The clerk will close the roll. There being 59 yeas and 67 nays, the motion does not prevail and the amendment is not adopted. There's an amendment at the desk. The clerk will report the amendment.
Nash moves to amend Senate File Number 4699, the unofficial engrossment as amended, and the amendment is coded A25.
I recognize the author of the amendment, the member from Carver, Representative Nash.
Thank you, Madam Speaker, and I appreciate the accommodation that you've made for me. Members, I think in my 10 years here, I have carried one healthcare-related bill, and now this is my first health-related amendment. I just don't do that. I have other focuses, but the A25 would make a very small change to the language of the bill. It's lines 1.9 through 1.20, and it would remove a cumbersome requirement for accreditation by the Joint Commission Accreditation on Health, or JACO, and allow for an accreditation that started in Norway from a thing called DNV. And I carry this amendment for the recognition that we need healthcare, mental health care assistance in our state. And specifically, this is for my district and other districts, as it would allow for this to be done there. The largest employer in Carver County, as I had said the other day, is Ridgeview Hospital, and they would like to do an adult day treatment mental health care facility, and they are currently under the DNV certification, and it's a very thorough, complete certification. And if we can remove this or insert this language, Chair Liebling, I would be very, very grateful, because we all talk about how important mental health is here, and I think we all realize it. And it's not something that is opposed by the department. They are neutral on this. The practical upside of it is that folks in Carver County and elsewhere that this will have benefit would be able to receive that by providers being able to do just this thing. I did speak to our mutual friend Sue Abderholden at NAMI. She is very much in support of this. And I think that underscores the fact that this is just something that is needed as we move forward. It's something that is incredibly prescient for our community. I've heard and seen a lot of mental health issues that would be helped by this, and Ridgeview is a fantastic provider that they think thoroughly through these things, and they want to actually serve our community. So I would be grateful, Madam Chair, and I know that there are a couple of others that would like to speak to this, but just for the benefit of Carver County and people who are in need of that mental health care that they can receive from Ridgeview, I would be extremely grateful.
I recognize the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker. I heard Representative Nash say there were others who wanted to speak to it, so I was going to hold off, but I'll just say that, so Representative Nash, I appreciate that you're trying to do something that you were asked to do recently, and that's really the problem with this. It may be fine, it may not be fine. I just plain old don't know, because no one ever brought this forward until like 2 days ago or something like that. I'm not aware there was a bill on it. It certainly didn't have a hearing. There's no fiscal note. I don't even know if a fiscal note is needed. So I'm just going to channel Chair Pulowski on the higher ed bill when he just said, this didn't get a hearing, so I would ask members to vote no.
Further discussion to the Nash amendment. The member from Hennepin, Representative Nadeau.
Thank you, Madam Speaker. And thank you, Representative Nash and Representative Liebling. I totally appreciate that. I was just notified about this as well. I did as much looking into it as possible, and what the bill does, as far as I understand, it just opens up the accreditation that currently in statute limits it to JCO, and it allows it to be opened up to other CMS and other Minnesota Department of Health accrediting agencies. It's not very often that we get a hospital stepping up and wanting to serve MA populations, especially with mental health. So if there's a way that we can accommodate this, and once again, I'm willing to work hard on it as you go to conference with this and try to figure out if it has a fiscal cost. I would hope that we could maybe reconsider. Let's insert this thing, and then we'll see how it goes. We can always pull it. You can always pull it out in conference later. But thank you, Madam Speaker. Thank you, Representative Liebling.
Any further discussion? To the author of the amendment, Representative Nash.
Well, thank you, Madam Speaker. And Representative Liebling, I would hope that maybe we could look into this further as you head into conference. I know this, that we all recognize that mental health is exceptionally important. And as I'd said, NAMI is very much in favor of this. I would hope that we can look at it, and if it truly is as your criterion were, that it has no cost, that maybe we could look at it further and you could add it in conference committee. It's so important. And to Representative Nadeau's point that it's rare that a healthcare provider is going to do this, and that just speaks to the truly creative nature of Ridgeview. They are an exceptional hospital. We talked about them and their ambulance service and how it's really leading in the state. I would hope that we would not stand on just that we didn't have a hearing, because we've all seen that things get put into conference regularly, and if we can make it so that this gets passed, I would say we should do it for the people who will get treated, who will receive care that they don't currently have the ability to get, so that for those who are in mental crisis can have somebody like Ridgeview there to give them a hand. And so I'm not going to roll call this. Part of me wants to, but I would just say, can we work on this to make sure, and if the chair would yield, Madam Speaker?
She will yield. Representative Nash.
Representative Liebling, this is not my territory. You know that. You've never had me in your committee. I'm doing this because I care about the people of Carver County, and I care about the treatment that is needed there. We all know that we're not getting enough. Will you work with Representative Nadeau, myself, Representative Schumacher, to see if there's truly no impediment to this, that we could put it in conference?
Representative Liebling.
Thank you, Madam Speaker. And Representative Nash, well, it's when you come on the House floor with something for the first time and people really don't know what the impacts of it are, it's very difficult to say that I'll just take this. I'm certainly always interested in helping the people of the state and getting them the care they need and so on. So I'm certainly open to thinking about this, but in my experience here, usually if you want something considered and you want to work with the chair of a committee and so on, usually you try not to get a negative vote on your bill on the House floor first, because it's kind of not a good way to start out. So, I'm open to finding out more about this. You mentioned this person, that person supports it. They've never told me they support it. So, if you wanted to withdraw your amendment, I'm certainly open to looking at it. I'm not saying I never will, but I also don't want to create sort of a precedent here that I have no idea why the hospital waited until the very last second to bring this forward. And I don't want to create a precedent where entities think that they can, come in at the very last second and then prevail on a member who wants to help their community to bring something forward and rush it through when we don't understand all the ins and outs of what the impact may be. And sometimes I've learned in having worked in this space for a long time, that sometimes you find out that there are impacts to things that you just have no idea what they are. So I don't want to accept this on the floor here. I want to really give it much more of a vetting. I don't know if the Senate has it or not. Maybe they do, but we certainly have had no opportunity to really find out what the ins and outs of this might be. So sure, I'm always open to working with members. I always meet with a member who wants to come and meet with me. You know, if we can find a time to meet, I never say no to a member to come and discuss an issue, so always open to that.
Representative Nash.
Thank you, Madam Speaker. Chair Liebling, I had referenced this earlier when we chatted in the garage. It was contained in language in House File 5124 that was offered by Representative Keeler. In the Senate, it is Senate File 5176, authored by Senator Morrison. I'll ask my LA to maybe make some time that we could talk about this briefly. It's important, and if not just for our county in Carver, I know that the Carver County delegation here takes things in our county very seriously, but I would ask for an opportunity to chat, and I don't want a negative vote position on it, so I will withdraw this, and I will take you up on your offer to meet, because this is very important. So thank you, Madam Speaker.
Representative Nash withdraws the A25 amendment. There's an amendment at the desk. The clerk will report the amendment.
Perryman moves to amend Senate File number 4699, the unofficial engrossment as amended. The amendment is coded A15.
I recognize the member from Stearns, Representative Perryman.
Thank you, Madam Chair. Members, as you can see in the underlying language, we already have significant requirements when hospitals are ceasing or curtailing certain services. This bill puts additional unnecessary regulations in place when hospitals need to make changes, and this includes increasing the timeline to announce changes, additional requirements around a public hearing, and how the notifications need to be provided. What's most concerning to me is the language, and it's just really one word, but the language says the department must impose penalties on providers rather than giving the providers the opportunity to work with the department to ensure they are complying with these requirements. There are significant additional requirements around notifications when these changes are being proposed, including who has to be notified, posting a notice in the main entrance, sending notice to the commissioner and local governments, a written public announcement, et cetera, et cetera, et cetera. If one of the new requirements is missed or not sufficient to the department's liking, the department must, and again I say must, impose a fine under this language. Members, as we have all heard this session, many providers continue to operate at a loss, including our critical access hospitals, nursing homes, and EMS providers. While I don't agree with these increased requirements, at the very least, we need to give the department the flexibility to work with providers to ensure they are complying before imposing these hefty fines. This amendment simply is one little thing, changes a word. This amendment simply says the department may impose penalties rather than must impose fines to lend some discretion to this process. So again, just a one-word change, and I will ask for a roll call as well.
A roll call has been requested. Seeing 15 hands, there will be a roll call.
And I please ask the members here to help some of the stress that these institutions are already experiencing, and this bill will still result in what we're trying to get done. It's just changing one little word so we have some flexibility with the departments and the providers. Thank you.
I recognize the member from Olmsted, Representative Smith.
Thank you, Madam Speaker, and thank you, Representative Perryman, for bringing this forward. I'm going to encourage members to vote no on this amendment, and I want to start by saying that since we gavelled in last January, there have been 11 unit closures, hospital closures, or relocations in our state since we gavelled in this session. St. Paul, New Ulm, St. Paul again, Bemidji, New Prague, Foston, Fergus Falls, Fridley, Coon Rapids, Staples, and Menominee. All of those communities deserve to know why they are not able to access the care that they were once able to, and be given tools to respond and plan their lives accordingly. We cannot have a Minnesota where every single Minnesotan has to go to an urban area to get good health care. We need to protect greater Minnesota and rural Minnesota so they can get health care in their communities. And listen, right now in greater Minnesota, I know that we are not in a great place, but it will get worse if we don't pass things such as this bill, this provision in this bill, to make sure that there is transparency and that there is real accountability if healthcare systems are acting in bad faith or just being secretive about their closures. A couple specifics that I want to talk about here with the must language. First of all, in subdivision 1C of this area of law, there are exceptions to these provisions. The two exceptions are if a natural disaster or other emergency takes place, a hospital or other facility doesn't have to go through this process, or if there is difficulty with retention and securing of staff and specialty staff so that they can deliver care. Those are the two most frequent reasons given for closures, and they're in the law already. And the commissioner has the ability to look upon those exceptions and grant those exceptions. So there's still a wide amount of working with the department in the law as it's going to be passed here. But to be frank, with the may language, we have not seen any fines that I know of to date that have ever been given to a healthcare system that has closed down a unit or closed down a hospital. And there have been some bad faith efforts. I'm not going to name any names on the floor, but there are documented tough closures where the community was not heard, where, for instance, a public testimony was not given. And that is why this bill is so important. So again, I'm going to encourage us to vote no, to encourage health care to be available to all Minnesotans, especially those in our rural and greater Minnesota areas. Thank you.
I recognize the member from Traverse, Representative Backer.
Yeah, Madam Chair, Speaker, excuse me, thank you, and members. First of all, Representative Perryman, thank you. Generally, we know a heavy hand does not provide care. And we had reference to Fergus Falls just here a minute or two ago. And Fergus Falls did, that hospital, which is Lake Region Hospital, did do a lot of notification. They did not want to close down. They did not want to close down. They want to provide, I'm texting the CEO right now, they wanted to provide care. The issue was because of other circumstances that make it difficult to provide care. The word must does not provide additional better care. What it does, you know, as serving on the Browns Valley Ambulance Service, our ambulance goes to Wheaton, Ortonville, and Graceville. And you've heard this from me before. If it's Friday night, Saturday night, or Sunday night when I'm on call, and we're coming in at 1 o'clock, 2 o'clock, if it's just a medical, or if we're running hot because it's a true emergency, and especially when it's a true emergency, we're running hot, I'm there, I become the ER. I don't get paid for it. I do it because I care and because there are requirements that makes it difficult to provide all those services. I'm not saying that the hospitals are not ready, but when you have a run with 2 or 3 trauma patients, that maximizes resources. And when you have the word must, that heavy hand, it's that like big brother from St. Paul. You know, instead of saying, hey, come on, let's talk about it. Let's see what we can do to work together, hand in hand. I'm not saying, this amendment doesn't say there will never be consequences, because you're right, Representative Smith. If there is poor care, we need to address it. At the same time, there are challenges that we have someone sitting in St. Paul that thinks they may understand what's causing the problem, but because they're not the boots on the ground, they're not. And let's face it, the individuals in St. Paul are as busy as anybody else. It's hard to get all the details. But when you add the word may, it works, people work together better, in my opinion. So great bill, it makes sense. It's important for those critical care access hospitals in greater Minnesota. Thank you for the amendment. Vote green.
I recognize the member from Chisago, Representative New Brindley.
Thank you, Madam Speaker, and members, and thank you, Representative Perryman, for the amendment. We had a good discussion about this when we heard this bill in committee, but we haven't seen any changes made. And I want to address a couple of things. Number one is that as a state, we pay for our Medicaid population approximately 68% of the cost of care. This is significant. We are going to continue to see, I mean, when we hear this number, 11 closures, now that's not hospital closures necessarily, that's individual services, units, lines of service, whatever, that encompasses more things. But we're likely going to continue to see this because we're not paying hospitals for the cost of delivering care. And I will just say we're going to hear a bill shortly that's going to exacerbate that problem. We are actively working in this chamber to make this problem worse. So we probably need to own a little bit that as a state, we are making this harder and harder and harder for our providers. On the flip side of that, when we fine hospitals, that money has to come from somewhere. And with a significant number, in fact, I've got this number somewhere, I'll find it. It's well over 60% of our hospitals are operating in the red. Right now, they're operating in the red. That means they are taking in less money that is going out. It is more expensive to provide care than what they are taking in. So with all of our hospitals operating in the red, I'm not sure how fining them helps change the landscape. It just doesn't. Now, I certainly acknowledge, and the language acknowledges, and existing law acknowledges, that there could be times where there are egregious examples wherein hospitals, hospital systems, et cetera, behave badly. But that's acknowledged in this language. Because if DHS sees that that's what's happening, they can impose a fine. But if DHS sees that they are acting in good faith, and yet maybe they receive a complaint from somebody in the community about how they went about meeting some of these requirements, well, now MDH must fine them. And that's problematic. And I want to draw attention to just a few of the requirements and how they could potentially be problematic. First of all, the providing notice to the public through a written announcement, which must be distributed through, quote, local media outlets. Is that all local media outlets? Is that radio stations? Is that cable TV? Is it newspapers? What does that mean? It is not defined. And so if a hospital provides that written notice, but they think, well, the TV stations don't run this, well, now we must fine them? That's not the state acting responsibly. I would also ask, in the very next provision, providing written notice to existing patients of the hospital or hospital campus. Well, what does that mean? Does that mean those who are being actively treated today? Does that mean, correct, does that mean folks who are in the building as of today? Does that mean people who have actively been patients in the last 6 months, year, 5 years, 10 years? Who does this notice need to go to? And what must the department impose a fine for. And you know, I mean, there's additional items regarding populations being served that I just think are problematic. This language is problematic. It is not clear. It directly adds to the costs of hospitals that are now paying for fines that MDH may think are actually not necessary, but we're forcing them to impose. The department should have some discretion here. The department can actively look at a situation and say, hey, they are acting in good faith. We're just going to ask them to remedy this situation. They need to provide notice to these people, whatever it may be. Maybe it's a corrective plan of action. Maybe it's a fine because they are acting egregiously. But both of those things are appropriate. And we should not assume that every single time a mistake is made, that it is done maliciously, because it's not. And more often than not, a corrective plan of action is sufficient. We should not be adding to the problem we already have in the cost of health care in this state by imposing unnecessary fines. This is a very good amendment. It is a strong amendment. We should give this discretion to the commissioner and ensure that we are acting wisely in these situations. Thank you, Representative Perryman.
I recognize the member from Isanti, Representative Johnson.
Madam Speaker, members, Representative Perryman amendment is a good one. Now, over the last couple of years, we've seen a number of different things. We've seen reduced penalties for those who commit violent crime, or bills to do that, lowering prison sentences, huge 200%, 300%, 400% increases in civil penalties for those who might make a mistake digging a ditch. And the answer to do that was because we have to make sure to do what those people make sure that they follow the law, while we reduce sentences for violent criminals and those, including those who commit homicide. But now we have the issue with the hospitals. Hospitals are running in the red. And this is a fine from $20,000 to $60,000. Some of these clinics on a $20,000 fine that are, especially in greater Minnesota, could shut down because of a fine like that. This is not going to help health care in Minnesota. Must is a harsh word. Now, with the term may in there, that gives the commissioner latitude to look at the totality of the circumstances, whether it's a $60,000 fine or working with them to correct the problem. I think working with them to correct the problem without a fine is going to help our community much better. All the communities across this state. Now, one of the things, you get a $20,000 fine because you don't put it in your local news outlet. How many? We've had a bunch of different papers just shut down over the last week, where we had to change the law so they could post it on the internet. Because they are no longer able to post it in the paper because there is no local paper anymore. But because there's no local paper, that hospital could get a $60,000 fine. Don't you think the commissioner should have some latitude to look at the totalitarian of the circumstances and try to work it out? Thank you, Representative Perryman. Everyone, please support this amendment.
I recognize the member from Polk, Representative Keel.
Thank you, Madam Speaker. Representative Smith, on your list was Foston, Minnesota. It has been a challenge with the community, but it is not closed. Now, unfortunately, the Department of Health did not respond to them right away when they wanted to have some discussion. and the community actually owns the hospital. Essentia provides the services. They did not appreciate the services that were being removed, and so they're working on doing something a little different. But when we're talking about the language of must and may, it becomes a real problem. Representative Johnson's point about news media, they have a good news media there, but there has been a real challenge in the messaging and what's going on. But the city council is in control of that hospital. And so while I know they have to have an agreement with the Department of Health, there's more to this, and I would hate to see them fined because of the requirement when they are actually trying to save the hospital and provide the services that they need between Bemidji and Crookston and Moorhead. It is an important service there. So I'm hoping that they will be able to get this fixed like they need to. They're working darn hard. The community is working really, really, there's a group meeting, I think, either last week or this week. I wasn't home for it, but even the Department of Health did not respond to them like they should have. So what I'm saying is, if we change the language to may instead of must, it helps the department as well as the local hospital to be able to adjust to what it is they need. And in rural Minnesota, it is so important to be able to work those things out. So I know the guidance from whomever is we should not accept this, but we're not talking about any money. We are talking about just helping the hospital, the local hospitals, and the department to work together, which is what I think their intent is to begin with. And so I would hope you'd reconsider changing the language on this so that I think it will help help our local hospitals to be able to work through those things, because fines only put them in bigger holes. It doesn't work well. I'm very concerned about many of my hospitals in my corner of the world. And what we would talk about in healthcare is those are the essential places that we go to get stabilized so that we can possibly need to go to a larger hospital. But those are very important to be able to take care of basic care for families and transport if we need to at that point. So I want to be able to protect my hospitals, and I would hope you reconsider this conversation. Thank you.
I recognize the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker and members. Well, I also urge members to vote no on the amendment, and I think it's the concern is a little bit overblown here. You know, we're not telling hospitals they can't close or can't close units or stop services. And believe me, there is an effort on that score too. And in the Senate bill, I believe there might be language to that effect. So we're not going that far. We realize that there are concerns about, that cause closures. But all we're asking them to do, all we're requiring them to do is give notice so that communities know and can respond and can understand. And this law has been in effect for a while, and some of them don't do it. They just don't do it. And the department, who works with and likes and is the regulator, really is loath to be the heavy hand. And in this case, we need that heavy hand because they just don't do it. They have it in their power to avoid the fines. All they have to do is notify. Now, if we have to, if this language isn't clear enough, we can certainly tweak that if necessary. If Representative Smith wants to do that, he can bring that forward in conference. But I think this is not an unreasonable thing to do. Let me say that in the positive. It is a reasonable thing to do to impose fines in these circumstances when entities just don't comply. And so I'm going to ask members to vote no on the amendment.
Further discussion on the Perryman A15 amendment. To the author of the amendment, Representative Perryman.
Thank you, Madam Chair, and thank you for all the robust conversations that we did have. As a legislator, I know I'm supposed to be the salesman at this point and sell you all on that you should vote yes for this amendment, but obviously I know that that is going to be difficult. But I do want to conclude that really just changing the word would make a difference. And I know there's some bad actors out there, Representative Smith, and I know there's closures going on. I'm empathetic to all that, but I guess I'm just looking that instead of a heavy hand to these places, I want to do a hand up. I want to help them be able to keep their doors open by collaborating like we do on the floor here. And, you know, it's going to be going on across the whole state, as everybody has said. But I think the intention of the bill would stay the same, changing the name. Maybe I'm wrong. But I also know that the heavy hand versus a hand up is important to my hospitals in greater Minnesota as well. And it's a shame that they are closing up, like you said. And I do, again, I know there's bad actors out there, but I don't know, maybe the glass is 3/4 full all the time, that I think there's a place in the middle somewhere that we can help these individuals and the commissioner make a decision before it gets to any penalties. Thank you.
The clerk will take the roll. The chief clerk will call the names of the members voting remotely.
Carroll.
There you go.
Carroll, no.
Carroll, no. Hewitt.
Hewitt, no.
Hewitt, no. Cagle.
Cagle, no.
Cagle, no.
Have all the members who wish to vote voted? The clerk will close the roll. There being 60 yeas and 67 nays, the motion does not prevail and the amendment is not adopted. There's an amendment at the desk. The clerk will report the amendment.
New Brindley moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A16.
I recognize the author of the amendment, the member from Chisago, Representative New Brindley.
Thank you, Madam Speaker. I think the intention was actually, I had intended to withdraw the amendment.
Are you requesting to withdraw this amendment? The amendment has been withdrawn by Representative Brindley, the A16. There's an amendment at the desk. The clerk will report the amendment.
Niska moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A8.
I recognize the author of the amendment, the member from Anoka, Representative Niska.
Thank you, Madam Speaker and members. The A16, the A8 amendment is regarding the provision in the bill that creates an insulin manufacturer registration fee. And Chair Liebling, I listened carefully to the discussion with Representative Nash about the process that was necessary, and so I did have a question about the process, if Chair Liebling will yield.
She will yield. Representative Niska.
Thank you, Madam Speaker. And Chair Liebling, I'm curious, because I looked at there was a bill related to this, but the language was quite different than the language that ended up in this bill. And so I was wondering if the language that's here on page 50 and 51 in section 18 was in a bill that received any sort of hearing before your committee.
Representative Liebling.
Madam Speaker, Representative Niska, I don't remember the exact path of this, but it was heard in the committee. you know, sometimes something is heard that where the language gets to the committee as a formal bill and sometimes as an amendment, but this definitely was heard in our committee.
Representative Niska.
Thank you, Madam Speaker. If Chair Liebling will yield.
She will yield. Representative Niska.
Thank you, Madam Speaker. And Chair Liebling, do you know where this language did come from, where it originated?
Representative Liebling.
Madam Speaker, Representative Niska, this is Representative Howard's bill, and so you'd really probably need to ask him if you want to know more specifically than that. It came to me as work that he had done.
Representative Niska.
Thank you, Madam Speaker, and thank you, Chair Liebling. If Representative Howard will yield.
He will yield. Representative Niska.
Thank you, Madam Speaker and Representative Howard. I was curious if you know the answer to that question. Was this language ever heard in a committee, the language that ended up in this bill?
Representative Howard.
Madam Speaker, Representative Niska, I believe this language was heard in the HHS Omnibus Finance Policy Bill when it cleared that committee.
Representative Niska.
Thank you, Madam Speaker, and that was sort of my understanding as well, that it was only heard as part of the entire omnibus bill that was brought forward. And so my next question, if Representative Howard will yield.
He will yield. Representative Niska.
Thank you, Madam Speaker. Representative Howard, where did this language come from, if you could help us with the drafting history of this language?
Representative Howard.
Madam Speaker, Representative Niska, I worked on this language. This is before your time here in the legislature, but I was the chief author of the Alex Smith Insulin Affordability Act, a bill that passed this body 111 to 22 that came into place because a young man, Alex Smith, at 26 years of age, lost his life because he was rationing his insulin that had increased in price by more than 1,200%, while insulin manufacturers raked in billions in profit. We worked collaboratively to pass this bipartisan bill, and this language is a way to update that program in a way that we think makes sense.
Representative Niska.
Thank you, Madam Speaker, and thank you, Representative Howard, for the discussion about the past legislation. I appreciate that. I was not here. I'm asking specifically about what this language is doing to update it. So I do have a further question if Representative Howard will yield.
He will yield.
Thank you, Madam Speaker, and Representative Howard. I'm curious, you said that this language is updating the Alex Smith insulin language. Can you help the body to understand specifically what this new language is accomplishing that's different from the Alex Smith insulin language that has passed in the past and on a bipartisan basis?
Representative Howard.
Madam Speaker, Representative Niska, this language inserts a insulin manufacturer's fee of $100,000 per manufacturer. It also includes an update that would reimburse insulin manufacturers, or a path for insulin manufacturers to reimburse for the insulin that they provide within that program. Currently, under current law, they are not reimbursed.
Representative Niska.
Thank you, Madam Speaker, and thank you, Representative Howard. If he will yield.
He will yield.
Thank you, Madam Speaker, and Representative Howard. I think you're referencing the insulin repayment account. This fee, $100,000 fee, I think goes into this insulin repayment account, if I'm understanding that correctly. So could you help us to understand what the purpose of the insulin repayment account is, and just understanding clearly how that is funded, if you could help us to understand that. Thank you.
Representative Howard.
Madam Speaker, Representative Niska, this is an account that will be used to administer this program. The Board of Pharmacy has a role in this program to provide reports. MNsure also has a role as navigators to assist folks. And so the purpose of this account is for the administration of this program.
Representative Niska.
Thank you, Madam Speaker. And if Representative Howard will yield for one more question.
He will yield.
Thank you, Madam Speaker. And Representative Howard, as I'm sure as you're, based on your work on the Alex Smith litigation, or the legislation, you're aware that there is litigation currently against the state of Minnesota claiming that that is a violation of the takings clause. And so I'm curious if this new legislation will somehow address the takings clause claims against the state of Minnesota relating to the current legislation.
Representative Howard.
Madam Speaker, Representative Niska, I'm actually not an attorney, so I'm not going to be able to comment on that.
Representative Niska.
Thank you, Madam Speaker and members. This is really kind of an odd piece of legislation. It's requiring the insulin manufacturers to pay $100,000 in order to get, I guess, back reimbursed that money. It's basically sort of circular as far as anyone can understand. It's interesting that we couldn't really get a lot of clarity from the author of the bill. The problem with the Alex Smith, or the current law, and the problem with this law is that the program was set up in a way that the state doesn't really paying for it. It was set up to basically force the manufacturers to provide insulin for free, and that does create pretty serious constitutional problems. If something is set up for a public benefit, then the public is supposed to pay for it. That's why there is a lawsuit under the takings clause for this. So my amendment does not remove that current program. It doesn't affect the current insulin safety net program. It just takes out this circular language that's being put into it, into this bill that's not going to solve the constitutional problem. So I urge member support.
Further discussion to the Niska amendment. Representative Howard.
Madam Speaker, first I'd like to request a roll call on this amendment.
A roll call has been requested. Seeing 15 hands, there will be a roll call.
Madam Speaker, I would urge a no vote on this amendment, but I think it's a really important opportunity for this legislative body to say whose side we're on. Are we on the side of Minnesotans who have been price gouged, who are rationing their insulin, who are sometimes forced with an emergency that literally could cost them their lives? To access emergency insulin, which is what this bill is about. And what this amendment would say is that the pharmaceutical companies who have raked in billions in profits, who've created this mess, have zero responsibility to share in the administration of this program. Now, members, again, we passed this bill on a vote of 111 to 22. That was a proud moment in this chamber on a bipartisan basis to show that we stood with Minnesotans who needed access to affordable insulin. We stood in this body to say never again is someone going to lose their life because they can't afford the insulin they need to survive. And this is a chance again for this body to show their support for Minnesotans by voting no on this amendment. I encourage a no vote.
Further discussion on the amendment. I recognize the member from Chisago, Representative New Brindley.
Thank you, Madam Speaker. And, you know, interestingly, there were 22 no votes initially, and I was one of those 22 votes, because it was easy to see the problems that were going to come down the road from passing that legislation, which is what we're experiencing right now at great cost to the state and great cost to Minnesota taxpayers. You know, this is a significant issue that we hear about all the time. We hear about how bad it is in Minnesota without recognizing the amazing access we do have. You know, when we passed these laws initially, it was very much, frankly, we put into law what pharmaceutical manufacturers were already choosing to do on their own. But of course, we couldn't take credit for it if we didn't pass the law. But that's what we did. We put into law something that these manufacturers were choosing to do on their own, and we have made it just punitive. And here's the problem with that. You know, I mean, we point all the time to other countries and how great it is and how inexpensive their health care is. Well, I'm not sure if you're aware, but in Canada, for example, they have access to 40% of the medications that we have access to in the United States. They do not have access. And when we're putting things in place exclusively to be punitive, because somehow with the $30 billion budget surplus, we can't figure out how to pay for things that we think are priorities, well, it tells you they're not priorities. And this is one of those things that is exclusively punitive. This is not functional. It's not a functional amendment. This is a punitive amendment. And in the United States, we enjoy access at an unprecedented level, seen almost nowhere else in the world. And this argument is just silly. So thank you, Representative Niska, for the amendment. I will happily vote yes on this today.
Further discussion. To the author of the amendment, Representative Niska.
Thank you, Madam Speaker, and thank you, Representative New Brindley, for pointing out for explaining some more of the context. Thank you, Representative Howard, for saying that this is about what side we're standing on. Here's the reality, members. The first thing any of us did in this building was to say what side we're on, and the side we're supposed to be on is the side of the Constitution. That should be the first priority that any of us have. It shouldn't be about playing politics. It shouldn't be about pitting one group of Minnesotans against another group of Minnesotans. It should be about protecting the state of Minnesota against frivolous or against unnecessary lawsuits. Time after time last year, members on this side of the aisle explained to members on that side of the aisle that laws we were passing were going to be challenged on constitutional grounds and were going to cost the state of Minnesota money. This is one of those times as well. This is one of those problems where members of the DFL trifecta are pushing forward with legislation that is unconstitutional, that will be challenged on legal grounds, and that will end up costing the state of Minnesota money, whether or not it benefits politically members on that side of the aisle. So, yes, we should vote in favor of the Constitution. We should put that as our #1 priority and not simply take political votes that are going to end up costing the state of Minnesota more money. Vote yes.
The clerk will take the roll. The chief clerk will call the names of the members voting remotely.
Carroll.
Carroll, no.
Carroll, no. Hewitt.
Hewitt, no.
Hewitt, no. Cagle.
Cagle, no.
Cagle, no.
The clerk will close the roll. There being 58 yeas and 68 nays, the motion does not prevail and the amendment is not adopted. There's an amendment at the desk. The clerk will report the amendment.
Nadeau moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A24.
I recognize the author of the amendment, the member from Hennepin, Representative Nadeau.
Thank you, Madam Speaker. Thank you, members. This hopefully is a interesting amendment, if nothing else. I'm super appreciative that somewhere along the line, Chair Liebling found $12 million to increase mental health rates on about 40 codes that providers are able to bill against. And so I think it's in 2025, I think it's a couple of million, and then it's another 4.5–5 million for in the out years. So it's about 12 million bucks. And for those of you that don't understand the process, if you work in the mental health field, you are able to, based on the presenting concerns of the patients that you see, you are able to bill certain codes for certain things. For example, if you're gonna provide a diagnostic assessment, depending on the presenting concern, that diagnostic assessment could be reimbursed anywhere from $134 per assessment up to $550 for an assessment. So what the underlying bill does, and what I'm trying to modify, is the underlying bill basically raises all the rates a little bit. All right, so it takes that money and it raises all the money a little bit. What this amendment does, and I'm hoping that Representative Liebling is going to say, Danny, this is a beauty, And because I think she's going to say that it's a super thoughtful, targeted approach that's intentional and focused on, on mental health providers, I'm hoping. But we'll see. So what this amendment does is literally it asks DHS to identify the most commonly used CPT codes and fund those to 100% of Medicare. The underlying bill raises the rates a little bit, all of them, up to 84% of Medicare. So most of you know that the state reimburses differently depending on a number of things, depending on the programs that you're in. Representative Smith and Representative New Brindley were talking a little bit about hospital closures. Hospitals are well, I'm not going to get into that. But there's different reimbursement rates. So what I'm trying to do is I'm trying to bolster those businesses, both nonprofit and profit, that provide mental health services by allowing the most commonly used CPT codes. And remember that providers get to choose which CPT codes they use based on presenting concerns. This is not DHS determining what they're paying. This is providers, all right? So it takes those most commonly used and raises those to 100% of Medicare. Now, this is a really good amendment, Madam Speaker. And I request a roll call vote.
A roll call has been requested. Seeing 15 hands, there will be a roll call.
Thank you.
I recognize the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker. Suddenly the chamber's so quiet. Representative Nadeau, I think you are super thoughtful and often have creative ideas, and I really appreciate your partnership on a lot of this and appreciate that you have concerns about rates under mental health, which we all do. But as you might expect, I don't think the same of the amendment. And so I'm going to ask members for a no vote. I mean, this just doesn't work fiscally. And this is extremely complicated stuff, and kind of the way we got to where we are is that DHS gave us kind of what different, kind of what we could get for different levels, and we basically put in as much as we could in the bill to buy as much of the percentage as we could. But I've been told that your amendment could possibly cost millions of dollars. It's out of balance. It just doesn't work. And so I know that Representative Hicks, who knows a lot more of the weedy part of this than I do, would like to explain a little bit more about how this works. That's why she's rising, and I hope that she'll have an opportunity to do that. But while I appreciate the sentiment behind this and the creativity, and of course that we have a shared concern, this just doesn't work. I think it would throw the entire bill out of balance, and we are doing in this bill the very best we can with what we have. So I ask members for a no.
I recognize the member from Olmsted, Representative Hicks.
Thank you, Chair, or Speaker, excuse me. And I would also recommend a no vote, but for a slightly different reason. So part of looking at the most used CPT codes, there's a little bit of a misnomer there, because in our current mental health system, we have a lot of stuff on this end of the spectrum, and we have some stuff on this end of the spectrum. And we're really missing a lot of stuff in the middle, where rates are not keeping up with demand. Things like partial hospitalization, things like day treatment, things like crisis respite services, which thankfully are in this bill. But there are significant pieces in that spectrum. And when we talk about mental health, if we only look at the most used, what we're really looking at is the most ability to access, which is not necessarily the most needed. So there's that piece. Secondary, CPT codes are not some willy-nilly thing that providers just decide to bill. CPT codes are designed and strictly outlined by the National Coding Institute. There are entire people whose whole job it is to be coders. And they outline exactly why you you can bill what and when, and which codes align with which services based on which pieces are in those codes. A provider could be cited, for example, for billing a code that doesn't meet those qualifications in an audit. So to just say they decide isn't really accurate, because they decide based on the service they're providing, and they should be deciding the service they're providing based on the needs of the patient, not based on which service is going to get them the higher reimbursement.
I recognize the member from Traverse, Representative Backer.
Yeah, Madam Speaker, thank you, and members. And, you know, Representative Nadeau, this is being creative. As we know, mental health we are in a crisis in mental health. One of the interesting things is rates, I would agree with Representative Hicks, rates are not keeping up with the demand. I remember my first HHS meeting in 2015, and they talked about the Olmstead ruling. And since then, we have been behind with helping the folks with mental health. So being creative, thank you. I would ask for a green vote on this one. Thank you, members.
Further discussion on the Nadeau amendment. To the author of the amendment, Representative Nadeau.
Thank you, Madam Speaker, and thank you, members. You know, how we have continued to do things here is literally driving 11 hospitals to close. It's forcing our mental health providers under massive duress. Direct service providers, it doesn't matter if they're residential treatment facilities, if they're day service providers, employment service providers, or school-based mental health providers, the status quo is crushing the businesses that we rely on to provide for the most vulnerable populations. I don't need to be lectured on whether or not presenting concerns in the professional, people out there that are providing those services know whether or not which code they should bill under. What I do know is that 100% of Medicare is still lower than the cost that it costs them to provide that service. So you can vote against this, and that's fine, and we're going to have a bunch of small increases in provider rates, which is great. I mean, I'm grateful that they're there. I am super grateful that we're going up to 84% of Medicare. I'm super grateful. But that is longitudinally not even going to remotely start to solve the problem that we have with massive increases of people that are seeking mental health services, both students and adults. And until we start thinking a little bit differently about how we deliver these services and help businesses basically bolster that model that they need to be successful, we will be back here all the time talking about how we can take $1 billion and raise rates by 15 cents. So thank you, Madam Chair. And thank you, members.
The clerk will take the roll. The chief clerk will call the names of the members voting remotely.
Carroll.
Carroll, no.
Carroll, no. Hewitt.
Hewitt, no.
Hewitt, no. Cagle.
Cagle, no.
Cagle, no.
The clerk will close the roll. There being 58 yeas and 68 nays, the motion does not prevail and the amendment is not adopted. There's an amendment at the desk. The clerk will report the amendment.
Novotny moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A2.
I recognize the author of the amendment, the member from Sherburne, Representative Novotny.
Thank you, Madam Speaker. Over the off-season, I was contacted by members of the Elk River Fire Department Auxiliary, and they came to me because they had looked at the statute, the Safe Haven statute, 145.902, Give Life a Chance bill. And that bill provides for the safe placement of newborn children in the care of either a hospital or with an ambulance crew. And they had found out about a thing called a baby box, a Safe Haven baby box, which is available. It's available in, it's currently legal in 16 states. And they were asking if I could just get an amendment onto this bill that would allow the existing law that we already have, the Give Life a Chance bill, and to allow for these boxes. And I'll tell you about the boxes. What they are is there's information on the outside of the box. And by that I mean it's something that has to go into a building. So it'd be like a safety, you're doing a deposit in a bank. If the door is opened, an alarm goes off. If something is placed in the box, a separate alarm goes off. There's video monitoring. There's a packet inside the box which provides information to the person doing the surrendering, which matches what is close to the state law asking for information. I believe it gives them a QR code or phone numbers that they can reach out to with the information that can be provided. So if there's a medical condition or anything like that that should be known, that can be submitted. In the past, right now, in the 16 states that I talked about, there's 227 baby boxes that are being used right now. And here's a statistic that I think is really, really important to remember. There's been 44 surrendered babies to these baby boxes, but the hotline number associated with these baby boxes and the QR codes has led to a hotline contact where over 150 face-to-face surrenders have taken place. What does that mean? Someone has known enough about this because of the publicity that they have looked up the phone number, they've gone to scan the QR code or looked at the number on the outside of the box or the website, and they've contacted the hotline and talked to the mother, and instead of placing them in the box, they found out the option that they could call an ambulance if they were willing to do that. Or they could, if they have the ability, take them to a hospital that's already allowed by Minnesota state statutes. And think about that number. So almost 4 to 1 that just the publicity associated with having these boxes has resulted in the face-to-face surrenders, and then in the situations where the mothers still want their anonymity. Like I said, 44 babies have been surrendered to these boxes, and these babies have given a chance to live. Representative Smith, when you were talking about the previous bill, you talked about how important it is to protect rural Minnesota. And this is the way that we can protect rural Minnesota for the people that have a long distance between a hospital where they could do the surrender in compliance with already existing Minnesota state statutes, or if it's an area like Representative Backer has where it is a long haul to get an ambulance, this gives an option. Now, there is no cost to the state. The people that want to do this, for example, my local firefighters auxiliary unit would raise the money themselves. They've already talked with the city council, and they know there's a fire station where it will be installed. They've already got plans and things in place so that they can raise the money, their own money, to pay for this installation and the monitoring. All they need is the people in this room and the Senate to say, yes, we think that it's important enough to give you this option to save a life. I think the publicity alone is worth it. And as I said, if we can save one baby, in speaking with Representative Liebling on this bill, she wanted to know if this law has been utilized in the state of Minnesota, and I don't know. I searched all over the Department of Health and Human Services websites. I can't find any records of it being used. But as I said, in the states where it's available, just having this has led to surrenders. We know it works where it's at. With that, I ask for a green vote.
I recognize the member from Olmsted, Representative Liebling.
Thank you, Madam Speaker, and thank you, Representative Novotny, for coming to talk with me about this the other day, whenever that was. The days are all blurring together, of course. I feel like I'm not ready to take this. I don't think we should accept this amendment today. I'm recommending that members vote no on this. Not no never, but not today. I think there are, as you said, you don't know if the current law has even done anything in the state. And I just want to point out to members here that when you look at what the current law is, it's not only a hospital where someone can surrender an infant under this law, it's also a healthcare provider who provides urgent care medical services. It's also an ambulance service, and another person other than the mother can also, with their permission, relinquish a newborn. But, this is a controversial policy. And I also did a little searching, and there are groups nationwide who really are opposing this. So it's one of these issues is kind of, on the one hand, sort of sweeping the nation, where a few states have done it, but there's also kind of some pushback on it. And I think one of the big reasons for the pushback was kind of what I talked to you about. What we're talking about here is abandoning infants anonymously. And we're in a kind of a world now where most of us recognize that people who are put up for adoption kind of retain a right, that they should be able to find out later in life where they come from. And many people now are interested in that. Some are not, but we just changed the law, in fact, last session to allow adoptees to find out, to get their birth certificate unsealed. So this is the direction that we're going. So to take a bill like this on the House floor without having had a hearing on it, without allowing people to weigh in from the adoption community, from the child welfare community, probably this should go to Chair Pinto's committee to be looked at, whether this is a good policy to use for newborns and for people who might want to give up newborns. There's just a lot here. And so while I really appreciate your sincere interest in this and your desire to do it, I'm going to ask members to say no. And, I hope that we can continue the discussion next year and learn more about this and have a robust discussion in a committee. Thank you.
I recognize the member from Stearns, Representative Damuth.
Thank you, Madam Speaker. And Representative Novotny, thank you for bringing this amendment forward. Members, this is an easy and a common sense green vote. Madam Speaker, has there been a roll call requested on this?
No, there is not, Representative Damuth.
I would like to request a roll call.
A roll call has been requested. Seeing 15 hands, there will be a roll call.
Thank you, Madam Speaker. We have heard in this chamber earlier this week on controversial bills that were brought forward saying if this would even, the things that were done on Monday, if this would even save one life, then we should do it. Members, I have no idea why you would potentially vote no on this amendment. This is a common sense amendment that costs the state nothing, that potentially could save one life, if not more. We don't have the data to show whether or not this has happened yet in Minnesota, but we know that it will. And not only would it potentially save one life of a baby, it could make the difference that mom in a very difficult situation, that mom, her life could be saved. as she makes a hard but the right decision for her situation. Members, I would encourage a green vote. I don't know why this board would not be lit up fully green to support the Novotny amendment to save even one life in this chamber by doing the right thing for the state of Minnesota. Thank you, Madam Speaker.
I recognize the member from Isanti, Representative Johnson.
Madam Chair, members, I never thought I'd be talking about this on this bill today. But Representative Liebling mentioned something that I have to bring up. She talked about adoption. I'm fortunate, I have two mothers. My mom who raised me, and my birth mother who gave me up for adoption. I have a lot of respect for both. It takes a lot of love to give up your child to have a better opportunity. I know we passed a horrible bill last year opening up those birth records. In my career in law enforcement, I've seen what it does when the biological family shows up in the adoptee's life, especially when they're in their early teens, really messes them up. So I got a lot of concerns about that. I had to deal with those kids in my career in law enforcement. But this amendment, Representative Novotny, thank you very much, gives an opportunity for a life to be saved. Life is precious. Now, without this option that Representative Novotny brings forth, it makes it harder for that to happen. And we have good people in his area, his district, that want to do this to save the lives of children, infant, newborn children. If we do not accept this amendment, and this would be a trial run to find out how it works, we are saying we don't care about newborn kids. Vote for this amendment.
I recognize the member from Anoka, Representative Scott.
Thank you, Madam Speaker. And Representative Novotny, I really appreciate this amendment. And as we've had a large discussion here already today about the struggles, especially in rural Minnesota, with access to health care. So this is giving a young woman, and sometimes a young girl, another option. I shared, I believe it was last week, maybe the week before, as Representative Liebling said, they're all blurring together now, but I shared a friend of mine that works in postpartum, and there was a 12-year-old that gave birth. Now, she went to the hospital. She went to the hospital. But imagine being a frightened girl, 12 years old. 12 years old. Maybe your family doesn't even know you're pregnant, and you give birth at home, somewhere, and you don't know what to do with this child. This would give that child, that mom, another option. We've all heard the stories of infants that end up in dumpsters or trash cans. This will help prevent that from happening. If you are pro-choice, this is a choice that a mom can make. Please don't take this away. This is a good amendment. Please vote for it.
Further discussion. I recognize the author of the amendment, Representative Novotny.
Thank you, Madam Speaker. Representative Dama, thank you for calling for the roll call. If you look at the hierarchy of needs in your life, and you're a person who is approaching adulthood, and you say to yourself, geez, I found out that I was adopted, and I want to know who my birth parents are because that's very important to me. That means 18 years ago, someone made a choice. Someone made a choice to let you live. The Representative Liebling, you know what I did find when I looked about birth records? I found in the state of Minnesota how about once a year there's a baby killed right after death by the mother because she's in a bad situation. We've seen longstanding murder cases where babies have been found after being killed after newborn. Nothing, this bill doesn't change anything other than opening just one more access to save a life. It's right in the bill. Give life a chance. That's all it does. Gives a chance for someone to make that blessed gift of life. I don't know how more simple to say this. This costs nothing to the state. It can make a huge difference in not only the life of the baby, but the life of the mother. I don't get it. Please vote yes.
The clerk will take the roll. The chief clerk will call the names of the members voting remotely.
Carol.
There you go.
Carol, no.
Carol, no. Hewitt.
Hewitt, no.
Hewitt, no. Cagle.
Cagle, no.
Cagle, no.
The clerk will close the roll. With 61 yeas and 66 nays, the amendment does not adopt it. There's an amendment at the desk. The clerk will call the next amendment.
Backer moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A7.
The member from Travers, Representative Backer.
Thank you, Mr. Speaker. I appreciate that. As several of you are familiar, when anybody faces emergency medical situations, it's quite emotional. Families and individuals are extremely emotional when they dial 911. And I know the other day, Representative Hugh and I had a robust debate about EMS. But one of the things that we are not addressing in the bill that we heard 2 days ago is the funding portion of it. It is extremely important that we fund this correctly. And I do want to have a shout out to the chair. I know over the years we have talked about EMS, and I really have appreciated her listening ear about the importance of EMS, emergency care, allowing me to share with her how we deliver care differently in greater Minnesota on the backs of the volunteers and so forth. So I do appreciate that, Chair. Thank you. We still have a crisis in Minnesota. And our crisis is right now, folks, each day 1,660 Minnesotans dial 911 for ambulance care. That's 50 1,000 calls on the average in Minnesota. And as we have heard, and as I have heard, and I know several of us other individuals have heard who serves on the task force and even in front of our committee, that there are several services that are at its last call. We are in an emergency situation here in Minnesota. We need to prioritize EMS. And what my amendment does is it says, Minnesotans, we took a vote here yesterday, 2 days ago, that, hey, and it was all green, that we did not, one of my amendments put that bill out of whack because there wasn't $120 million there. Representative New Brindley pointed that out during our debate. So what I looked at is where could we prioritize Minnesotans when they are having some of the greatest challenges in their lives. Folks, when someone dials 911 and it's a true emergency, people are facing some of their most critical challenges in their lives. We owe it as a body to help fund that service. And that's what we're doing. I'm looking here, I'm prioritizing Minnesotans. I'm prioritizing those 1,660 individuals who are dialing 911 today, tomorrow, the next day, and it will be sometime, will be one of your loved ones. It will be one of your neighbors. So I would ask for a green vote on this to prioritize EMS. It is emotional, it is important, it is life and death. It's time that we as a body says, yes, let's prioritize EMS. Thank you, members.
The member from Hennepin, Representative Agbaje.
Thank you, Mr. Speaker. Members, I would recommend a no vote on this amendment. This amendment, unfortunately is actually taking the money from another emergency that we had addressed last year, which is the fact that Minnesotans, both citizens and residents alike, do not have health insurance. So this amendment would essentially go back on a program that we had put in place last year that's already showing benefits in the fact that more Minnesotans are becoming insured. Healthcare providers across the state support this policy because they have seen firsthand that health issues become much worse and much more complicated and more expensive when care is delayed. And so with more people getting treated earlier, that means they can spend more time with their families, they can work, and they can continue their education without setbacks. Providing health care for more people will save money over time. And the expansion of Minnesota Care to cover low-income, undocumented Minnesotans lowers the number of uninsured Minnesotans and reduces uncompensated care costs, and those savings benefits all of those savings benefit citizens and non-citizens alike. And I do want to be sure that the record is clear. We heard our colleagues say that this amendment would prioritize Minnesotans. Undocumented Minnesotans are Minnesotans. And the money that we have already spent on expanding Minnesota Care prioritizes all Minnesotans. And those Minnesotans also pay into our system. They do pay taxes. In 2018, where we had the most recent data, $31 million in state taxes came from undocumented people without Social Security numbers. Because immigrants, especially undocumented immigrants, use our healthcare system at lower rates, despite contributing billions of dollars to insurance premiums and taxes, they in fact actually help subsidize the U.S. healthcare system and offset the cost of care incurred by other Americans and Minnesotans. At the end of the day, everyone needs to use ambulance systems. They need to use our healthcare system, and what we've done through expanding Minnesota Care allows us to do that. Health is wealth, and what we did to ensure that every person has the ability to be insured is important, and we need to continue to advance that value. So again, I would encourage members to vote no on this amendment.
To the author of the amendment, Representative Backer.
Yeah, Mr. Speaker, I'll ask all members a question. You dial 911. It's a loved one. it takes 40 to 50 minutes for an ambulance to show up. How would you feel? Vote green. Thank you, members.
Seeing no further discussion, Representative Schumacher.
Thank you, Mr. Speaker. I would request a roll call on this amendment.
Roll call requested. Seeing 15 hands, there will be a roll call. Seeing no further discussion, the clerk will take the roll. The Chief Clerk will call the members who are voting remotely.
Carroll.
Carroll, no.
Carroll, no. Hewitt.
Hewitt, no.
Hewitt, no. Cagle.
Cagle, no.
Cagle, no.
The clerk will close the roll. There being 60 yeas and 67 nays, the amendment is not adopted. There's an amendment at the desk. The clerk will report the amendment.
Quam moves to amend Senate File Number 4699, the unofficial engrossment as amended. The amendment is coded A20.
The member from Olmsted, Representative Quam.
Thank you, Mr. Speaker. And this amendment probably should seem familiar because the governor a few years ago during the pandemic issued a proclamation. He basically did this, but it took a little time to do that. The 11 closed facilities that were noted by a rep earlier on, one of the big contributors besides money was staffing. And when we hit the pandemic, we had a lot of issues with staffing. And this would just say, hey, the governor was right when he did it before. So in these type of circumstances, we would have that in statute so that that would turn on when those type of emergencies happened. That way you might be distracted by something going on and not think of it, or it might be delayed. No, this would be addressed, and it'd be addressed at the hospitals where they don't have the staff to stay open, don't have the staff for 24/7. And I think this is common sense. I ask for a green vote.
Point of order, Mr. Speaker.
Representative Jordan, please state your point of order.
Thank you, Mr. Speaker. This amendment is out of order under Rule 3.21. This amendment amends Chapter 148, which is not amended in the underlying bill. And so, Speaker Tapke, I ask you to find it out of order.
Advice? Seeing none, I find the point of order well taken. Seeing no further amendments at the desk, we will now have the third reading.
Third reading, Senate File Number 4699, as amended.
Third reading. The member from Travers, Representative Backer.
Yeah, Mr. Speaker, one of the greatest concerns that I have with this bill is with the increased cost to Minnesotans, along with the decreased options that we're going to see with Minnesotans, and also hurting our insurance. What my grave concern is our critical access hospitals in greater Minnesota. I believe we have about 72 of them now. I could be off there, but these critical access hospitals are not flush with money. We talked about some closures of departments of hospitals here this afternoon on the floor. We talked about Representative Keel. The hospital, one of the hospitals I represent in Fergus, they had to shut down the mental ward treatment in their hospital, and that was a staff reason. These hospitals are struggling. If we keep down the path that we are seeing right now and the policies that's been set forth over the last 4 to 5 years, the challenges that EMS is having, we are going to see those same challenges grow. They are facing those challenges. So I'm really concerned that what we're going to see here with the policies in this bill and what's been passed in the prior sessions, we continue to put a nail in the coffin. This is irresponsible. This is very uncountable. You can't keep running a hospital in a deficit. It doesn't work. Or you cannot provide the services that are needed. So I would vote no, even though I do want to I do like the EMS provisions that are in this bill. There are really some good EMS provisions in this bill, and thank you, Chair, for that. That gives us flexibility. It doesn't solve all the problems, so I do appreciate that. I do want to shout that out when there are good provisions in the bill, so thank you so much for that. At the end of the day, though, I will be voting red because families are struggling. This does not help provide stronger rural health care, especially for our critical access hospitals who are already in many situations facing a red. In many situations when us EMS professionals are coming in late at night, especially if we're running hot, we're there helping the ER. So vote red on this bill, members. Thank you.
The member from Hennepin, Representative Nadeau.
Thank you, Mr. Speaker, members. It's been a great discussion today, and I want to thank Representative Liebling for putting together a pretty comprehensive bill. And I'm going to start with there's a lot in this bill. There's a lot of good things in this bill. I may have preferred that our investments in mental health go a different direction, but it's still good. It's still good that we're investing in mental health services. Simplifying the mental health billing codes. Seriously, that's a good thing. Changes to our case mix reviews. I mean, a little bit weedy, but still, that's a good thing for counties. School-linked behavioral health grants. Super important. I mean, the next step is to combine some of those direct county spending and our rates to ensure that we're leveraging all of those funding things together to the best of our ability. So a good thing. Expanding the pharmacist practice, reducing or increasing dispensing fees. I can't remember. I think that was Representative Bonner that brought that. That was that's a good provision in this bill. We have yet to see, and it's interesting that we didn't talk about Representative Bierman's HMO conversion language at all, but it'll be interesting to see how that unfolds moving forward. But the clunkers in the bill, and I think we've alluded to them a little bit. The prior authorization. I mean, make no doubt about this. I mean, we've had fiscal notes ranging from $193 million to $9.8 million. This is we do not know what the cost of this is. And members, I've said this before and I want to reiterate this. This is not about access to service. This is about payers. That's what this is. This is about making sure that we've got a second opinion on some of these things that are super costly, recognizing that treatments change over time, and not every provider in every place has the right answer every time. And having that backstop, that's a good thing. At the same time, reducing some of those things that are unnecessary and redundant, absolutely. But there is not peace in the valley on this. This is a costly provision down the road that could bust the budget in a big way. And honestly, there's nobody here that can tell us what this could possibly cost. And it's not going to improve access at all. It's just going to deter, it is literally about money. It's just money. You know, I'm always surprised when we can't make the simplest changes. We talked about hospitals closing, and I'm going to take the opportunity now to, hospitals don't want to close, clinics don't want to close. They don't want to move from an ICU to a CCU. That's not what they want to do. Everybody in the healthcare industry, and I don't care if you're a direct service provider for a 4-unit group home or you're the highest paid doc in an emergency department, those people are there because they want to serve people. And they want to do it to the best of their ability. They do not want to close. And if we're going to measure the effectiveness of our statutes based on the levies imposed by the Department of Health on some organization that needs to close, I think that's the wrong measurement, Representative Smith. We could have easily taken that and moved that to May. There's discretion there. I would say that since they've never imposed a fine, that's good. Imposing fines, I mean, if you want to talk about, talk to Representative Lesnikar about fines in residential, in nursing facilities. $1 million in fines. That is not a good thing. We don't want fines. And my other concern, it's not a huge one, but we've got this, we haven't talked about it, but we've got these unaddressed concerns with, you know, the prohibition on vertically integrated health plans. And I recognize that looking at it from the outside, you know, everybody should have to be paid the same. But that's not how our system is built. You know, value-based payments, you know, some people get paid more, some people get paid less, some have capitations. I mean, this is all about building the networks, and we're going to talk a lot about networks in the next bill. We're going to talk a lot about them. So providing that flexibility for our healthcare partners to work within the constraints that we're giving them is something that we really need to focus on. Our system is so integrated and it's so complex, but at the same time, it's so fragile. The things that we do have an effect. I am confident that Representative Liebling, as she takes this to conference, is going to fight for the positions, and she's going to fight to try to produce the best bill that she can. Because of the clunkers, primarily, this is primarily about prior authorization, and I hope others talk about this, and I'm willing to work on this, and I appreciate all the work that's been done so far, but it is not enough. It is not ready to be in this bill, members. It's too risky. It's one thing to have, you know, force a hospital to, you know, they're going to pay a fine if they close. I get that. I can live with that a little bit more than I can live with the idea that we have no idea what the cost is going to be to remove that partnership between a payer and a provider. Providers can still provide that service. It's just about having that other partner that stands right alongside them. Because if we don't have them, now you're going to pit patients against doctors. That's the last thing we want to do. So there's a balance here to find. I don't think we found it in this bill, but I do believe that Representative Liebling is going to continue to work on this, and I appreciate that. So thank you, members.
The member from Chisago, Representative New Brindley.
Thank you, Mr. Speaker. I'm just going to touch on a few things that I think are important, some that we've talked about, some that we haven't. Number one, I think the most significant problem we have with this bill are the prior authorization provisions that simply are not paid for. We should all be concerned about that. You know, we have an obligation to balance our budgets. We have an obligation to make sure that when we are passing legislation, we can pay for it. And that's simply not done in this bill. When a fiscal note says that we can't quantify or we're not going to estimate those costs, but the costs exist, we as a legislative body still have an obligation to pay for it. We can't ignore the fact that there is a cost. This is going to be a huge problem when forecasts start coming in. These are forecasted expenses. It's going to come in and it is going to blow up our budget in the tails with no accountability. It's a huge problem, and frankly, it's an irresponsible way to govern. I want to touch on the fact that this bill completely obliterates the account that we use to pay for reinsurance. Reinsurance is a program. Minnesota was nation leading in developing and implementing a state reinsurance program. After Obamacare was passed, states across the country saw skyrocketing premiums. The cost of insurance increased dramatically, while at the same time, counties in Minnesota were losing all choice in health care. And by implementing reinsurance, we stabilized that market. We brought the costs down and we brought choice back to the market. Two really important things happened with that. A couple of years ago, Democrats changed the reimbursement. I think they changed the attachment point. I don't remember what the mechanism was now. But they changed reinsurance, and premiums immediately increased about 15%. They rolled it back the next year, realizing their mistake. Democrats rolled that back, and premiums dropped again. This is a direct impact. This is not theoretical. This is not hypothetical. This is a direct impact on the cost of health insurance for Minnesotans. And by eliminating all funds to pay for reinsurance, we are completely disrupting the stability of the market here in Minnesota. It's irresponsible. I want to talk for just a moment about this county-administered MA model. Interestingly, quite a few Republicans initially had signed on to this bill, not knowing that it was a bait and switch. Not knowing that it was a bait and switch. And in fact, we were told in committee that the goal of this bill, the goal of this legislation, is to eliminate managed care organizations. Get rid of them. That's the goal of the bill. However, managed care organizations perform an important function, and it seems that I'm going to have to remind folks of this every year, because I certainly had to last year. But we use managed care in delivering health care for a reason. And when we say managed care, we're talking about private health insurance companies, health insurers, the folks that you would think of, Preferred One, Blue Cross Blue Shield, et cetera, all of those insurers that we use. And as a state, we use these managed care organizations in the delivery of Medicaid for several reasons. The most basic of which is that the MCOs assume all of the risk. So if there is an event that would cause extensive use of insurance that year and the insurers lose money, the insurers are on the hook for that. They don't get to come back to the state and say, hey, please give us more. They're on the hook for that. They absorb those losses. Now, on the flip side, they are limited in their reward. So health insurers, MCOs, do not have the ability to deny claims, to make things difficult for patients, and then just pocket all of that extra cash. They don't get to do that. If they have too much profit, that comes back to the state of Minnesota. There is no incentive from MCOs to behave badly, because the money goes back
back to the state anyway. They don't get to just profit that. So they assume all of the risk, but they are limited in their reward. So that is the most fundamental reason that we use managed care in the state of Minnesota. However, there are additional things that MCOs do that we know. In fact, we had a committee in December, and the testifiers told us there is no mechanism in fee-for-service, there is no mechanism when the state takes care of this to manage care coordination. When we use MCOs, when we use these managed care organizations, there is a holdback. They don't get all of their money unless they meet certain metrics. Are kids receiving their immunizations? Are people receiving preventative health care? Are people doing their screenings, et cetera? There are a number of criteria that managed care organizations must meet in order to get paid. And if they don't do those things, they literally don't get paid. So there's a massive incentive for MCOs to ensure that folks are receiving the preventative care that they need and to make sure just overall that they're receiving the care that they need. So the thought that the county administered MA model that is in this bill, that the goal of that is to eliminate managed care, is problematic to say the least. It's problematic to say the least. The reality of this bill is that it will increase the cost of health care for every Minnesotan across the board. This absolutely is going to increase the cost in a variety of ways. It's going to decrease options. This bill is going to decrease options. It is going to remove options for Minnesotans, and it's going to destabilize the health insurance market. I get that this stuff is really in the weeds, but I assure you folks, this is problematic. This is a bad bill, and I'll be voting no today.
The member from Olmsted, Representative Quam.
Thank you, Madam Speaker. And, first of all, why do we have so many amendments? It's because our bills don't seem to be heard in committee. And frankly, that's where we ought to have a lot of the discussion. Healthcare is broad and huge, but we don't seem to be addressing to try and decrease the cost, address additional information, healthcare's priorities. EMS, and in emergency, EMS services is how you get to survive to get to health care, how you get health care and get to the hospital. But we've had multiple amendments voted down that would show that, if we voted for them, we'd be putting priority on EMS, the front line, to many people getting life-saving care and getting to the hospital. But we haven't shown the priority to EMS. We tend to try and have a narrow definition for some people bringing amendments for germaneness. Even though we have bills, especially at this time, they're very broad. And well, we should have talked about it in committee. But we never got a hearing. I think we would do better if on an omnibus bill or a mega omnibus bill where you've got 2, 3 more topics, areas together in a bill, that if it pertains to that area, we should listen and discuss. The cost of health care has been touched on. In the past several weeks, multiple school districts are having huge financial problems. I know one local district is moving into statutory operating debt. Healthcare touches every sector of our communities. And the costs and increases affect every sector. Others have already spoken and touched on it keeps going up. And frankly, Minnesota needs to look at allowing options, collecting the right data, and doing a better job. We are losing teaching staff and programs in schools, and other parts of the sector are hitting the same. When we have 20 or more % increases in multiple years, that makes it unaffordable to do what we've been doing in many sectors. So this bill, yes, it's health care, but it's much broader. And that deserves a discussion and input from both sides. And frankly, we saw fit to hold hearings during the non-session time on certain topics. But the biggest topic in greater Minnesota is often health care and EMS, and we should have had regional committee meetings to discuss those. We even actually voted so that we could move something the first day of session. But we find ourselves again, we don't have time, it's not germane. Oh, we didn't hear that in committee. Let's start doing a better job because our people deserve it. Thank you.
The member from Hennepin, Representative Bonner.
Thank you, Mr. Speaker, and thank you, members. You know, this is a really incredible bill. There are some really remarkable things in this bill. From protections to make sure that when someone decides to shutter, that we can notify the community and allow for those necessary pieces for folks to adapt to how that's going to take care or how that's going to address their care. You know, if you're expecting a child and your hospital is about to close, you're going to want to know about that. There's so many pieces in this bill that I'm really proud of, but I'm going to speak just mostly to mine for the sake of time and brevity. But, you know, we talked today about prior authorization. And I want to say that we've had lots of consternation about this, but I want to be very clear about something. The items that are in the bill, the items in the list, have a 95% approval, almost across the board. And of the 5% that aren't included in that number, a number of those folks simply give up because it's too hard to jump through all the hoops to get the necessary care. And you know, prior authorization was intended to talk about things like safety, efficacy, and cost. And there is certainly a role to be played for prior authorization. This bill does not suggest that we should do away with all prior authorization. What it does is say, in very specific situations where there is a high level of approval, where it is actually putting barriers to necessary care in the way of patients, where it is delaying care for no gosh darn good reason, then maybe we should be thinking about how we do that. I hear lots of members talk about how we address things like red tape. How do we streamline? How do we cut costs in a way that makes sense? If these things are getting 95% approval, members, this says to me something is broken. If we are asking providers to spend on average 13 hours a week filing prior authorizations, that is time that doctors and nurses and clinicians are not in the room with a patient. They're not asking, or they're not answering the questions of their patients. They're not looking at the signs and symptoms to deliver the best possible care. Instead, they're filling out paperwork. Paperwork for things that are likely to get approved anyway. And let's talk about chronic conditions briefly. Chronic conditions, in the top 20, you're going to see the usual suspects: the diabetes, the hypertension, the cardiac diseases, right? Things like this. Things that aren't going away tomorrow. These are things that are going to get approved. But we're not saying you can't do PA for chronic conditions. Just to be clear, you can still do PA. But what we're saying is, if a patient gets approved through the prior authorization process who has a chronic condition, they don't have to jump through that same hoop every single year, year after year after year after year. If you have diabetes, members, and you're on a specific type of insulin, your diabetes is not going away. You're not going to suddenly not need your insulin. You're not going to suddenly not need your prescription for your hypertension medicine. That's not going to happen. Now, yes, formularies could change and things could alter, but realistically, patients are on specific medicines for a reason. Why bodies react differently to different, or body chemistries react differently, I don't know. And where it makes sense to move to something else on a formulary, doctors can and will recommend that. They do it all the time. They do it every day. But when someone is stabilized on a particular brand of insulin, for example, that works with their body, where that individual is stable and healthy and doing well, it does not make sense to switch them. And asking them to jump through extra hoops when their diabetes is not going away really doesn't make any sense. This bill is a lot to do with common sense. It has a lot to do with streamlining the process, cutting costs and red tape and minutia where it's not necessary, and ultimately providing better care for patients. So I want us to remember that as we talk about prior authorization. And yes, I appreciate that we have some challenges around understanding what will come forward. Those are the same challenges we have every day under prior authorization. They don't change under this bill. It's the same. And again, 95% approval. That's the part you need to remember, 95%. Finally, I want to just move on from there and say thank you to Chair Liebling and to my colleagues who've done incredible work on this bill, both in support of the prior authorization, but also for pharmacies. I know that many of our folks in this room are well aware that pharmacies are disappearing at an incredible rate across the state. We have lost so many pharmacies just in the last couple of years. It is untenable. And in some communities, the local pharmacy is that trusted source, is that place where you go to get basic care for things like getting your vaccine shot, getting a pregnancy test, little simple things that can be done in a pharmacy by the pharmacist. Pharmacist Bob, who you've known for the last 20, 30 years. He knows every medicine you take on your list. He knows your kids. He knows your children's medicines. He knows when you need to take another test to make sure that your blood sugar is under control. All of these things are important. So we did two things this year that are important. The first was making sure that we updated the rates that are paid to pharmacists for the services they deliver. That is critically important, and it is based on the most recent rate study to make sure those pharmacies stay solvent, those small, independent, mom and pop businesses in Nisswa, in your small towns across the state. And finally, we did, during the pandemic, we allowed pharmacists to step up in a really big way. We asked them to help be that incredible part of the continuum of care, to be able to provide vaccinations in the pharmacy for folks. If you live in greater Minnesota, and I can tell you from my own family's experience, if the nearest clinic is 45 minutes to an hour away, they're not going. But my grandfather will travel the 15 minutes from Lake City down to Nisswa. He would go down there and talk to the pharmacist to get his shot, to get his medicine, to pick up anything else he needed. He would do that because he knows his pharmacist. He trusts his pharmacist. And with the end of the year, those permissions for pharmacists and pharmacy techs and pharmacy interns to continue to be part of that care continuum in a time when we're falling behind would expire. This bill makes sure that they can continue to deliver those vital services. And so I want to thank the chair. I want to thank the members for the robust conversation in committee. I want to thank you all for the robust conversation on this floor and for the opportunity to make some clarifications. But above all, everyone, please vote green.
The member from Clay, Representative Schumacher. So the member from Rock, Representative Schumacher.
Thank you, Mr. Speaker and members. And before I begin with a few of my closing thoughts, I did have one question for clarifying that I needed to have answered, and it's about the medical debt language that's in the bill. So I'm not sure who might be able to help, but my understanding is, okay, Representative Reier, before I ask you to yield, my understanding is that there's similar language that was running in the Commerce Policy Bill, and the Commerce Conference Committee has wrapped up. So what is the intent with the language that's in this bill as it moves forward to Conference Committee, if the member will yield?
She will yield. Representative Reier.
Thank you, Mr. Speaker, Representative. My intent for this language is to not be carried forward. We have it covered in Commerce Policy. Thank you.
Representative Schumacher.
Thank you, Mr. Speaker, and thank you, Representative Reier, for that. I just wanted to make sure I had heard that was the case, but I just wanted to get that on the record there. And so just to start out with a few thank yous to Representative Liebling and the committee for some of the good stuff in this bill, and for the discussion today and the ability to take a few of the amendments that were offered, and also for the tone for some of the amendments that couldn't be offered, that it wasn't no, not ever, but just no, not today. That was an appreciated tone for us, and I know that there are a number of members on the Republican side who are interested in continuing to work on those pieces and those provisions as you go through the conference committee process next week to hopefully try and get some of those things wrapped up as well. There are a few positives, as were mentioned earlier in this bill, the mental health reform and the funding that went for that. Of course, there's always more that can be done, but it did seem like there was an attempt to make this a priority in this bill as we've seen it progress through the different stages, and so we were happy for that. We're happy to see that pharmacists are going to get some relief in this bill for what they're doing. Again, just a few different provisions in there, putting the student loan repayment program on the revolving loan system will be helpful, and carrying that as part of the Department of Health's bill, really important, but really a minor piece compared to some of the bigger other pieces, but worth a mention anyway. Adding the assisted living to the summer internship program that we took in committee is appreciated, and the groundwater thermal exchange permits piece, having that in there because groundwater is a big part of the health committee every year. And so we're just happy to see that. The challenges that we have with this bill today, and while I will be recommending that members vote no, we've heard a bit about already, it's the increasing cost to premiums. And I've talked about this before, the added mandates and the changes that are made to prior authorization, that's going to add to the cost of premiums and the cost of care. And with the prior authorization, it's always worth remembering that the state uses prior authorization too for the programs that it administers because they see value in what they're doing there. And so that's always an important point to keep in mind when we have the discussion about prior authorization, and we do know that will increase the cost of premiums there. There is a reduction in the amount of choice moving forward in healthcare options for MCOs by restricting new non-for-profit managed care systems. For-profit managed care systems. We would have preferred to keep that just out of the bill completely and allowed for competition to take place in that area. And of course, I'll be asking for a no vote today because we are restricting the innovation and barring healthcare systems in their ability to pivot when they need to, and drawing out the process for any changes that a healthcare system or a hospital may want to try and attempt to do in order to meet the needs of the community the best way that they can. And sometimes that's a difficult discussion to have with the community, but their inability to pivot it entirely is troublesome as well. There were opportunities to look at other fixes that would have helped save the state and the taxpayers and our healthcare system money by not doing some of the things that were mentioned above, but also by looking at the reinsurance piece that Representative New Brindley had mentioned in her remarks. If that is currently set to expire, and so we have a healthcare system where we'll be seeing shifts in how we present and how we pay for health insurance, and having the expiration of the reinsurance program in the state is going to offer disruption. At the same time, we're seeing at the federal level that the advanced premium tax credit is set to expire too, another piece that's disruptive. And experts are expecting that premiums will be going up by another 30 to 50% based on just those two changes. And so we're going to be coming back to this discussion year after year until we decide to have something that's a little more solvent in there. We could also work on relieving some administrative burden. In this bill, we move to a more burdensome piece on the health records. We could be moving towards a piece that aligns more with HIPAA and just following the federal lines with that. And we could also be looking at allowing for nurses to be able to practice more in line with what other states offered with the Representative Quam amendment in the Nurse Licensure Compact and moving into that. We also saw some proposals this year from Representative Nadeau that we had on the floor today with how we should be prioritizing the spending that we have for increases in funding. We've heard from Representative Murphy throughout the year on different proposals that would change the way that we think and talk about health insurance and health care, and those are all things that we could be doing, and we'll continue to be discussing and analyzing as we move forward. But for today, I would recommend a no vote for that and a few other reasons, but thank you for your time.
And to the author of the bill, the member from Olmsted, Representative Liebling.
Thank you, Mr. Speaker, and thank you, members, for the good discussion today, and especially for the fact that it's only been a few hours. And hopefully I won't extend that by more than a couple more. I want to just respond to a few things that I have heard here this afternoon. One that I've heard from a couple of members has to do with the Representative Smith's bill on hospital closures. There's been a little misconception here, and that is that we're stopping them from closing. It's been said a couple of times in different ways. That's not what the bill is doing. The bill is just strengthening current legislation that requires disclosure, that they let the community know if they're going to close or close a service, and have a public hearing so that people can understand what's going on and weigh in on it. That seems really common sense. This is not hurting them. It's not stopping them. It's a pretty modest thing to do, in my opinion, and that is in the bill. Just going back, I heard Representative Backer talk at the outset of the comments here on third reading about critical access hospitals. And I just want to note that the amendment that was on the floor to take away health care from Minnesotans would have hurt critical access hospitals. You know, critical access hospitals throughout the state, when people are uninsured, it hurts their bottom lines. They, you know, even if we're paying, I know we hear a lot that we're paying below the cost of care. I want to say it's pretty hard to know what the cost of care is, so I don't accept that, but it is better to be paid than not to be paid. And often these critical access hospitals are struggling when they don't get paid. So having coverage for them is a good thing. So members, be careful what amendments you put on the floor. Talking about prior authorization, I was going to respond to a lot of what I heard. I think Representative Bonner did an excellent job on that. But I just want to reiterate there that changing prior authorization, trying to rein it in, is about reducing bureaucracy for providers and patients. And there is a cost to this bureaucracy. It's a big cost. It can be, and it is about care. It is not only about money. It's about money for the insurance companies, that's for sure. And there's no question that they save money by putting a lot of administrative barriers, bureaucracy, between patients and care that they should be getting. And oftentimes it seems that there's an attempt to get them to give up and not get that care. But this is, I think for many of us, this is about care. It's about letting providers give the care that they know the patient needs and letting the patient get that care without unnecessary barriers that don't make any sense. And in particular, this is also about our workforce problems in healthcare, because when you waste a provider's time, they can't see as many patients. It's as simple as that. And they have been telling us that, and providers are burning out because of not because they're tired of seeing patients, although that can happen too, but because they're tired of doing unnecessary paperwork that isn't why they went into medicine or nursing or their profession. That is not what they went in to do. So this bill, I'm very proud of that changes that Representative Bonner has championed on prior authorization. That is one of the best things about this bill. I want to just say a word about the reinsurance issue. Reinsurance is not a big issue in this bill, but we are taking some money that was left on the bottom line of the reinsurance fund of the premium security plan account. And this has been referenced a few times. And I just want to note for members, we're taking almost $9 million in this bill, repurposing it in this bill from that fund. This is just the leftovers on the bottom line. This is not doing anything big. We already decided to stop funding this account. So this is just what was left over. And so I just want to note from this report, it tells how much we spent on reinsurance. On the actual, what we paid to the insurance companies. Just want to be clear what this is, because people watching might not know what this is. So in order to keep insurance premiums down, we've been paying to the insurance companies a portion of the claims they have to pay for. So instead of the companies paying them, the state of Minnesota, with some help from the federal government, has been paying for them. And so the numbers, just to give you an idea, so for fiscal year 24, it was $213 million. And these are, of course, projections, but for 25, $250 million, for 26, $280 million. So the almost $9 million that's left on the bottom line that we're using in this bill, if we could debate reinsurance, which we're not going to do right now, but what we're doing in this bill is not your problem, folks. That's my point. And let's see. Just in general, I just want to now do a few thank yous before I close. And of course, we couldn't do anything without our nonpartisan staff around here, and we have a fantastic team that we've been working with. Elizabeth Clark-Vest, Sarah Sunderman, Randy Chun, and Joe Harney have just been great, and their job isn't over, so they can't go home and forget about us yet. Our wonderful partisan staff, Joe Durheim, Jonathan Cotter, Krista Niederhofer, and Josh Sandy, who are, again, just all wonderful. They do such great work for us. I just want to really thank all of the committee members on both sides of the aisle. It's been a real pleasure to chair the committee over these 2 years, and you've just all done great work. And to Representative Schumacher's point, the conversations have been pretty cordial and substantive, and this is a hard space, and I appreciate every member who wants to serve on this committee, because it's not easy. There are easier things you can do in this legislature. And to talk about healthcare and worry that the things that you're doing, how they impact people's lives is no small matter. So I very much appreciate that. And I especially do want to call out Lead Schumacher, who's always great to work with and understands what's going on and is so helpful in bringing his knowledge and understanding. And absolutely my vice chair, Robert Bierman, who's just been with me every step of the way and just is an amazing, amazing member and vice chair and just so talented. And then finally, the sergeant's office. This has been kind of a challenging couple of years, and we've so appreciated the way they've shown up for us and made sure that we could do challenging things and feel safe while doing it. So I think that covers pretty much everybody. And with that, members, I would just say my theme for this bill, tiny target, big impact. I also, let me not forget, my seatmate here reminded me to thank our page, Natalie Wavra, but all of the pages, because it is quite a job for all of you. Thank you so much for what you do for us here. And with that, I'm going to ask for your support on this big, important bill with not too many pages and a teeny tiny target. Thank you.
Seeing no further discussion, the clerk will take the roll. The clerk will call the members voting remotely.
Carroll.
Carroll, aye.
Carroll, aye. Hewitt.
Hewitt, yes.
Hewitt, aye. Cagle.
Cagle, aye.
Cagle, aye.
The clerk will close the roll. There being 68 yeas and 59 nays, the bill is passed as amended and its title agreed to.